just take it away.
Yeah, that's fine. Thanks. Okay, I'll just share my screen and we'll get started. Okay, so good afternoon, everyone, and thanks to GV Synergy and Mentalk for inviting me here tonight. So my name is Shakif. I'm a current GP registrar. I'm about 5 years out from graduating, so I think I finished up when the majority of you guys might have been starting. And I guess today I've just got 10 minutes, I think, and I'll spend it being a bit more pragmatic and explaining things from a perspective of someone who's graduated 5 years ago, a little bit about internship and GP life as well. I'm glad I'm going first because I've had a look at the lineup for this afternoon, and I think there's some WSMS presidents and whatnot, and I do recognise a student from my days of cardiology residency as well. But I'm glad I'm going first. So where am I now? Just to give you an idea, I'm an academic registrar working as in the Department of General Practice, and I might have seen some of your faces throughout the year. I'm doing an extended skills term, and at the same time, I'm working clinically as well in Southwest Sydney. I have taken my time through general practice training, actually. So whilst I'm 5 years down the track, I haven't sat exams yet. Just to give you an idea of what has been involved since graduating, I was in the class of 2015, and since internship and residency, I decided to do some other things. And it was only last year that I went through and started GP training. And this year as well, I've continued on with that. But last year, I still took 6 months away. I guess the message from this is just to let you know it's okay to take time in choosing which specialty training program you want to go into. Don't stress too much about it if you're not sure. Just get through your internship and residency and figure out things as you go on. Now, I'm going to skip through these because these are a little bit boring and pictures. But that's me cooking some papadums or something similar earlier this year. But basically, do other things outside of medicine is the primary message from these pictures, which I've brought along from a previous presentation. It's not all about work, and that's something I want you to remember as you head into internship. And I'm seeing there's something on chat. Right. Yeah, look, so I've taken some time to do some things outside of medicine after residency, and I'd encourage you guys to consider that moving forward as well. I know this is talking about internship and residency and what are things that you can do, to have a good time. But I do want you to remember that it doesn't have to be a rush towards specialty training straight up. Okay. All right. Now, so you're going to be an intern, and I just will give you, well, I'm going to be honest, and I'm going to say that it is going to be crappy at the start. It's not going to be necessarily easy. Some of the AIMS placement students, you might have a slightly easier transition, but the first few weeks may well be stressful, and you might think, hey, I don't think I can do this. Regardless of how good your med reg or your surg reg is, they may or may not be amazing, but at the same time, you're starting a new job and you're having to get your bearings. You're having to learn different processes and things specific to your rotation as well. So it's okay to know, it's okay that those first few weeks might be a struggle. Obviously, it's good to have someone to confide in. And if you really are struggling mentally, it's good to speak to someone about it. But I'm not going to say it's going to be easy from day one, but looking back at it, you get through it. It's going to be hard, regardless of how good your hospital is, and you might have seen hospital health checks and those sort of things. But regardless of the situation, it will get better, and that's something to remember. And having a look back, yeah, it was pretty terrible. I think I would be leaving at 7, 8 p.m. every afternoon on cardiology, and I had an amazing reg. But that was me just being slow with discharge summaries, being a bit unsure about what to do, taking my time to do bloods. But like I said, it does get better. So I've got a few quick tips, and I think the rest of the speakers will go through, specific things, but I've just got a couple of things and two main ones at the end that I want you to remember, if anything, from my talk tonight. So these three things in general, when you're on your ward rounds and on your AIMS placements, just figure out what your reg is trying to say, because they might use terms that you're not aware of. They might ask for things that you're not sure why you're doing it. So it's okay to ask for clarification, not obnoxiously, obviously, but for your own learning, one, for the patient's benefit too, and ensuring that you follow up appropriately on the management plans as well. I put in there once said or teach your students. And what I mean by that is that, look, it's going to get better. And then once it does get better, don't forget about the students that are on your placement. You guys are the students now, sure. But you're then going to be JMOs and you're going to have third years, fourth years, fifth years around with you. And we're in a privileged profession where we're taking care of patients, and that's our primary objective. And we need to be collaborative in our approach and teaching our colleagues, learning from our seniors and teaching our juniors as well. And so don't forget to take that time to explain to your students, this is why we're doing this is why we're doing that, this is how you do a cannula. And even if they give themselves a needle stick injury, be polite, it happens. But it's all part of a learning process for students, as you guys would be well aware, being fifth year students yourself. Leave is something that's really important, and I'd encourage you to take it. And that's obviously a bit difficult with COVID. So maybe if you want to travel up to the South Coast, maybe North Coast a few weeks after or something. But I would encourage you to don't bank it up so that you get paid out at the end of residency. Not that you necessarily can at some hospitals. But I think I ended up taking 7 weeks of leave in residency because of all the public holiday credit and other leave that I had. And that was with 4 different international trips. And so I'd encourage you to just take that time to enjoy yourself. It's okay to not work for a few weeks at a time. And don't worry about, wanting that extra pay at the end of it all. Now, 2 big things that I want to mention are, don't miss those important events. And when I say that, I mean, wedding events or birthdays or any other family functions that you would otherwise like to go to. And if you have notice of when it's going to be and you've got a shift coming up, it's completely fine to try and swap out of it. And I'd encourage you to do so. Obviously, don't be that guy or girl who's always trying to get out of their afternoon shift or their Saturday shift. But it's also important to not compromise those important things in life. You're going to, get through internship and residency, and you're not going to regret having gone to that particular function, but you might regret having gone to work to miss out on that particular function. So just think about how your future self might think of what you're doing, with your Saturday shift that is clashing with that other event. Put yourself first. It's okay to, obviously, if you've got an acutely unwell patient on after hours or whatever, you have a duty of care. And the other thing I do want to say is force yourself to spend time doing the things that you love. And I hope you do that in med school. And I would suggest you continue that, but don't think that because you're now working, you have to give up whatever classes you're taking, whatever sport you're playing. Yes, it's a struggle, internship and residency, but I don't think there's that much going on to suggest that you need to give up everything else in your life. Don't think to yourself, hey, this is just the hard yards I need to do, and I'll enjoy life when I'm a reg, or I'll enjoy life when I'm an AT or a boss, because you're in most of you, I would imagine, are in your early 20s. These are obviously, some of the best years of your life, and you don't want to just make an excuse of working hard now to enjoy it later when you can do both at the same time. So those 2 things, if anything to take out of today, I would encourage you to take those 2 things moving forward. We talk about CV building and all those extracurricular activities that you might be thinking about in internship and residency. And I want to be pragmatic about this. Yeah, you can join RMOA. Yeah, you can do courses, audits, research, etc. The main thing I want you to ask yourself is, what is the reason you're doing it? If it is to get into your specialty program and it's something you really want to do, great. But at the same time, don't fall into that trap where you're just doing it because everyone else is doing it. And I'm referring in particular to a blog post I came across on a podcast recently, and it's talking about the mimetic trap. I don't have enough time to explain that in detail, but I'd encourage you to have a Google of that. It talks about making sure you know the reasons why you're doing something. And I think that applies to work in general, but also these things about, extracurricular activities. Don't do things just because you think it should be done or your peers are necessarily doing it. But the main tip would be speak to people who are in the training program that you're interested in and to figure out what might be necessary, whether it is something you might enjoy, and then make your decision from there on in. Diplomas and masters and further studies is always a question as well. And that was always at the back of my head, starting from internship as well. I would say don't think about it, because your first 6 months, you want to be settling in and doing a good job and, you know, taking care of patients. Obviously, you want to continue that during internship and residency, but you just might not have enough time to put efforts into studying a diploma or a master's. If you do, good on you, but I would suggest thinking about it slightly later in internship or residency. And there's lots of things that you can do, and some of those things I've mentioned there. Personally, I was keen on PEDS or GP or physicians at one point, actually. And so the Sydney Child Health Program is something you might want to consider. That used to be called the DCH. Masters of Medicines with special subspecializations and different aspects can be helpful for other specialty training programs. I can't shed light about how much points or whatever it might give, unfortunately. And I'm interested in public health and preventative health. And if you find immunization sexy, you want to learn more about, how to treat a population and benefit, public health is all about prolonging life and preventing disease. I'd encourage you to do it out of your own interest. Public health is something that I'm looking to be a part of in the near future. And for me, GP allows me to do that. Going on, financial advice. I was just looking at the event invite and it mentioned financial advice. And I just have two things. One would be, don't forget to do salary packaging. And the other thing is, you're starting to work, or perhaps for the first time, if you haven't been working during med school. But remember, there's courses and things that are pretty expensive, regardless of what specialty training you do. So have some left over for those things in particular. Don't go buying a Toyota 86. That's not something I did. I'm just giving an example. But don't blow all your money straight away. It's a good idea to save a decent chunk of it, and remembering that courses are expensive, regardless of, like I said, whichever specialty you're doing. For GP exams, for example, we're going to be forking out $4,600 to sit writtens, and then another 2.5, I think, for clinicals. So, I mean, that's incentive to pass at the very least. Now, I want to mention Notion. I know I have got a couple of minutes left, and I want you guys to write this down as well, because it's something that I've come across recently. It's an app you can use on your desktop or your phone, and it's a great studying tool as well as organizing things, in your day-to-day lives. I use it for study, and I've only recently discovered it thanks to a YouTube video. But it's a great way to organize your notes, and it's 10 times better than using Microsoft Word or anything else that I've used. So if anything, take those 2 points that I mentioned earlier in the slides and Notion, write that down, because it's a great app and you might be able to get like full subscription with your uni emails. So have a look into that, because I think it's just a really cool tool to be able to organize your life. And when it comes to study time for exams, it's something that I've been using, and I'm really, really, I'm loving it. Yeah, as sad as that sounds. Just a couple of reasons as to why I enjoy general practice. Like I said, I love public health and preventative care, and I like, someone coming in with a problem and me trying to figure out what to do about it. And there's a fairly big variety of things that I see day to day. I would normally put a list on, but I'm wary of the time I've got. And again, ask yourself what you enjoy, not what you think you should enjoy. And that's in regards to picking a specialty as well. And that's hard to say sometimes until you're in it. But again, ask yourself why am I doing this with regards to work and those extracurricular activities. And for GP registrars, I'm more than happy to take questions offline as well. The main two things really is to talk to GP registrars. And then, like I said, feel free to email me afterwards. I'll put it at the end of these slides. And that main point again is don't miss out on important events because of work or study. Apart from that, just relax and try and get through internship. I wouldn't be worrying too much else about GP training per se. Just focus on being a good intern and having a good time. And during GP training, those are some random things that we can talk about in further detail and you can look into once you're in it after residency or a couple of years after. Again, don't miss important events because of study or work. And I'd certainly recommend becoming an academic reg. I get to do a few different things, including marking your papers and teaching a bit as well across the years. And I'm having a great time. And this afternoon, I'm going to Harvard Online. It was meant to be overseas, but because of COVID, we've now shifted to a medical course education course online. But yeah, there's lots of different opportunities you can get as an academic reg. All right, so I'll leave it at that. And I've left my email there if you do want to have a chat about any of these things or anything that I mentioned earlier about life as a GP reg and what training involves or any of the other things that I've mentioned. So feel free to give me a buzz. And apart from that, good luck and thanks for your time. Sorry, I've gone a little bit over time, Dharmesh.
That's all good, Shakif. Thanks for that. That was so reassuring. And now I think we've got Nicole that's going to be talking a little bit about GP Synergy.
Very quickly. I won't crack into the other time too much. So I just wanted to let everybody know what GP Synergy is if you weren't aware. So GP Synergy is the regional training organisation for doctors becoming general practitioners or specialising in GP in New South Wales and ACT. So we do both we run the program for both colleges, the Australian General Practice Training Program for RACGP and for ACRAM, and we work with the colleges to make sure that you guys receive the training that you need. Probably one of the biggest things you guys need to be aware of at this time of your medical careers is that you can apply to GP training during your internship year. And that's probably one of the biggest things because then your residency year is considered as the first year of your training program. So if anybody has any questions, feel free to contact us on our website. I'll pop it in the chat, or you can send me an email. We have career counselling sessions. We're doing JMO education webinars as well. So if you need some additional help, we just had recently the antenatal care for JMOs where you can just have a bit of extracurricular time to revise some key topics. But any help that you need or any questions you have about GP training, feel free to get in contact with us. Thank you so much, Dharmesh, and thank you for organising this. It's fabulous.
Thanks so much, Nicole and Shakif, and have a good night. And thanks so much for doing that. Next up, we've got Ankita, who's going to be talking about prescribing medication, writing up a death certificate, and claiming overtime. Lots of fundamentals for internship.
Hey, is that working?
Hey.
Sweet.
Yep.
Give me a sec. Yeah, so I was just going to go through a few quick things that you guys wanted to know about internship.
And it's showing the speaker notes view rather than the main view.
Oh, I don't know how to fix that. Wait.
Maybe we can all just don't look ahead.
I can help you if you want. Just if you go to the view part in the top column there, in your in the top bar, the view.
Yeah.
Yeah, and then you just click that, and then you should be able to unclick presenter view.
Is that working?
Yep,
Yay!
Yeah, sweet. Okay. So just before I start on those topics, a few quick tips for internship. Make friends with all the other JMOs because you will need them when you've got your shitty overtime shift where you need all the help you can get. Find things to enjoy in every rotation, even if you say, for example, don't get along so great with your team, find something else to enjoy in the rotation. Maybe you really like the patients, maybe you really like the pathology. Ask for help when you need it. Remember to prioritize your tasks, and you can say no when people ask you for non-urgent things. Remember to document everything thoroughly, even though it can be a little bit annoying at times, because at the end of the day, if something happens and people look back through things, your documentation is the only thing that's going to be able to show what you and your team did at that point in time. So the first thing is death certification. It seems really tricky at the start before you've done one. And once you've done one, it's pretty easy from there. Just remember to note down the time of death when you're informed by the nursing staff that someone has passed away, because a lot of the time you won't be able to get there straight away. The first one can be quite unnerving, especially if it's out of hours. But see if you can somehow even go with your reg or something when they're certifying one in hours, so you can go through how to actually do it. Remember, it's not a priority if they're even if they call you 10 times about it. If you have other things to do them first, because you can't really do too much to help someone who's already dead. In terms of how to actually examine someone, it's a pretty simple head-to-toe examination. If there's family in the room, it's usually nice just to explain what's happening to them and get them to step out of the room while you do your examination. So call out their name, squeeze their shoulders, do a sternal rub to make sure that they're not responsive. Pupils have to be fixed and dilated. Make sure you can't feel any pulses, no heart sounds, no lung sounds. Note down the time of death, and you have to inform the consultant that the patient has passed away. It's a little different if it's out of hours, if it's overnight. For example, in that case, if it's an expected death, you would probably just call them sometime in the morning when they've woken up. If it's an unexpected death that has happened out of hours, it probably shouldn't be you as a JMO notifying the consultant or the family at that point in time. It should be someone a little bit more senior. Just exactly what you've done here on this screen. Just remember to document it all in PowerChart, the examination, time of death, and who you've informed. It's usually good to have a quick template that you can pull up for every time you're asked to certify a death. The paperwork involved with it, there's 3 pieces of paperwork, and you just have to make sure before you fill them out that you know whether it's a coroner's case or not. A coroner's case is essentially being something that they count as a suspicious death. Because once you've filled out all the paperwork, the family get to take the body and bury it and do whatever else they want to, and it becomes hard for the police then to go and pull it up if they then decide it's a coroner's case. The first thing is a cremation certificate. All of these pieces of paperwork are usually pretty self-explanatory. So I've just kind of half filled out the photos that I've got here. Cremation certificate basically says that you've seen the body, you've certified who this is, and they can be cremated. Nothing too difficult on that one. The next one is the coronial checklist, which if it's not a coroner's case, you should be ticking no to everything, all of the number 1 to 13. If any of them are yes, you should probably escalate it to someone. Remember to sign it down the bottom, and this has a back page as well that you need to fill, or you will be called the next day or at some point in time to go down to some random office and fill them out. And the last one is the cause of death, big A3 piece of paperwork. Again, the first section is relatively easy. If you read the questions, they're pretty self-explanatory. In part 2, you just fill in the patient details. For place of death, just write down whichever hospital you're at. For the cause of death, that's where it can become a little bit more tricky. If it's not your team's patient, it's probably good, rather than just reading the notes, if it's appropriate, to ask the team who's taking care of the patient what they think the cause of death should be. Some consultants are quite particular about what they want filled out on here. So the direct cause of death, the first thing is going to be the direct cause of death. For example, this patient came in with a pneumonia and they died of respiratory failure. Their cause of death is going to be a pneumonia. The second section there is for things that they pre-existing conditions that they have that made them more susceptible to the pneumonia. So for example, if they've got a background of bronchiectasis and pulmonary fibrosis. And the last one is any other significant comorbidities that they have. In terms of the column next to it, which asks for approximate duration between onset and death, the first time I filled one of these out, I went through and tried to calculate how many days they had pneumonia for, how many years they had these conditions for, but you can literally just write days or years for them depending on how long they've had it for. In the last section, you just fill out your name. Again, just write which hospital you're at, give them your APRA registration number, and you don't really have to fill out any of the other details. Don't give too much of your personal details. Okay, any questions on certifying death? Sweet. I'll move on to the next one then, which is prescribing, which can be scary at first. And again, you'll do a lot of it. At the start, you'll probably even be scared of prescribing Panadol, but then you'll give it out like candy. So it'll differ on your hospital, whether it's paper or e-meds, and you'll get training on how to use each of them. I guess the thing you should always remember when you're prescribing something is that it has to be safe for the patient. Why are you actually giving this medication? Are there any contraindications to it or any precautions? For example, do they have renal failure? Do I need to decrease their dose? And of course, the actual dose and the frequency that you're going to be giving it out. Some easy resources to help you out. So ETG, if you want to look up medications by conditions, AMH and MIMS are pretty good when you're trying to look for dosages and precautions for medications. And the other thing about prescribing is that you as an intern, it is going to be your job to reconcile the admission versus discharge medications. This can be quite tedious at times because you're looking through what they came in on, what have we changed, and what have they been discharged on. But it is quite important, and that's going to be one of your main roles as an intern. And there have been cases where people have filled out these discharge medications incorrectly, and patients have had to be readmitted because they're taking the wrong medications. Sometimes if you've got a good pharmacist on your ward, they do something called an MMP, which is a medication management plan, where they essentially do all the work for you for admission versus discharge meds, and you can copy and paste it. Okay, just a few quick classes of medications that you will be regularly charting. Anticoagulation, so it's either going to be prophylactic or therapeutic. Every patient that comes into the hospital, unless they're already on therapeutic anticoagulation or they have some sort of contraindication, make sure you chart them something prophylactic for DVT prophylaxis. So that's just going to be, you'll get used to this, so you don't have to memorize the dosages or frequencies at this point in time. But I guess just knowing that Clexane versus heparin are the main two, depending on their renal function. Their renal function is pretty poor, you would tend to give them heparin, and the dose and frequency depends on their body weight. In terms of therapeutic, a lot of patients already come in on things like NOACs and warfarin. If they do, you just have to be aware that they're on it. If they come in on warfarin, remember that you do have to monitor their INRs, and you might have to stop it if it's, for example, a surgical patient. And there's also bridging. So if a patient is on a heparin infusion and you want to eventually discharge them on warfarin, for example, you just have to make sure that once you start the warfarin, it can take up to 72 hours or longer to become within a therapeutic range. So just remember to continue your heparin infusion while the warfarin is taking effect and becoming therapeutic. The next one is analgesia. So I guess the principles of providing analgesia and prescribing analgesia is that you want to provide the minimal amount required for the patient, but you also don't want them to be in pain because that's pretty poor patient management. Being in pain means they're going to be at increased risk of complications and a prolonged hospital stay. Always just start with your simple analgesia. So paracetamol, remember, it can be oral or IV if they can't eat or drink. NSAIDs can be oral or PR. In terms of paracetamol, if they're coming in with a condition that's likely to be painful, as long as they don't have any contraindications like poor liver function, I would chart paracetamol regularly or at least on the PRNs because they will need it at some point in time. And you want to make sure that it's there for when they need it. In terms of opioids, just be a little bit careful when you're prescribing them in terms of, make sure they don't have, make sure they don't have allergies, any prior history of dependence, which means that you just be a little bit more careful about giving opioids, but it doesn't mean that someone who's got a known history of opioid dependence doesn't get opioids if they're in pain. Other things to be careful of with opioids is if you are converting between different opioids or converting between, for example, an IV and subcut route, make sure you triple check your dosages before you give in. And again, as with the anticoagulation, make sure you're aware of the precautions for certain medications. And the next one, like other common requests you'll get asked all the time, things like aperients and antiemetics, especially on surgical terms. It's often a good idea to chart a few aperients and antiemetics in the regulars or the PRNs just to make sure the patient has it when they need it, to make sure that you're not coming back 5 days later for the patient to say that I haven't opened my bowels for 5 days. There's no, I guess, drawback of charting things like aperients regularly. If they're opening their bowels, they'll just say, no, I don't want to take it. And the other thing that you guys wanted to talk about was insulin. Um, Usually, if patients are on insulin, they'll tend to be on a basal bolus regimen, or you guys will start them on one while they're in hospital. So the way you chart it on the paper charts is that the different types of insulin have to be written on different columns. So the Novorapid in the first one, which is TDS, and then the Lantus in the second column, which is just before bedtime. And then there'll be a section on the other side of the chart where the nurses should be documenting the BSLs every time they check them and ketones. It's also, when you look at an insulin chart, I guess when you're asked to chart a new dose of insulin, for example, if you can see from the second part of the chart that their BSLs have been, for example, trending high after lunch every single day, you can definitely increase the dose of pre-lunch insulin charted for them. So if they were trending high, you would say, maybe I can increase the pre-lunch from 10 to 12 and see how that goes. An insulin charting scale is on the bottom left-hand side of the chart, and it's essentially a way that nursing staff can administer additional insulin without calling a JMO if the patient's BSLs are trending on the high side. So typically, the sliding scale will be charted. So if the BSL is between 10 and 12, give this many units. If it's between 12.5 and 15, give this many units, and so on. And if it's above 20, they'll typically tend to call you. If you don't know what to chart for a sliding scale, then usually you use that example that's on the back of the chart for 2, 4, 6 units. But you do have to be careful in that you have to titrate it to the patient's insulin sensitivity. If someone comes in, for example, on 2 units of insulin TDS, then this supplemental scale is probably appropriate. However, if someone is, for example, on 40 units TDS, 2 units of insulin is going to do nothing for them. In that case, the sliding scale, you might go, instead of a 2, 4, 6, maybe you would go for like a 10, 13, 16. There's no really right or wrong answer here. It's just that you have to continuously monitor it and update it if required. The other thing you guys will be asked to do is if a patient's hyperglycemic, you will often have to give them stat orders of insulin. So the type of insulin you tend to give is either Novorapid or Actrapid because they're fast acting. Again, the dose is going to depend on the patient's insulin sensitivity. For example, if you're called for a BSL of about 24, if someone is not on insulin to begin with, you would probably just give them a small dose of, say, 2 to 4 units. See how that goes. If it doesn't bring it down enough, then you can give another dose on top of that. However, if someone is on 10 units TDS and then 12 units at night, 4 units probably isn't going to do much for them. You would possibly give them 6 or 8 units. If someone's on an even higher insulin regimen to begin with, 40 units TDS, 6 units is going to do nothing for them, give them a bit more. I guess the principle is once you give them a stat dose, make sure you tell the nurses to recheck the BSL, say in like 30 minutes or an hour, and let you know what it is to see if you need to give them further doses or not. And just remember, you can always give additional doses. It's a bit hard if you've given too much to begin with and they've gone into the hypo side. So that's why I usually start small because I know I can always give more if needed. Any questions about prescribing or any particular medication classes that I haven't gone through? See, the last bit of my thing is about overtime. So I think I'm pretty sure all New South Wales hospitals at this point in time, you can claim overtime online. So the online one is 3 months if retrospectively, and if you're claiming overtime for some reason, which is more than 3 months ago, you can use the paper forms. So the working hours, I think, might differ a little bit by hospital, but they should be set at the start of the term. So medical terms, for example, for us are from 8 a.m. to 4:30, surgical terms are 7 a.m. to 3:30. And you can essentially, anything you work before or after that, you should claim as overtime. Remember to claim all your overtime. Interns are cheap, like people don't care about giving you another $34 for working an hour. You can claim things like mandatory training, so all the heady modules you'll have to do. And if you're starting early pre-rounds, like you will have to do for a lot of rounds, make sure you claim that time too. There's a set of, so this is a screenshot of the online system where you can claim it. There's a set of 10 criteria there. So going from medical emergency to hospital-based outpatient clinics, which essentially they don't have to be verified by a consultant. They will go through automatically if it's any one of those criteria. So don't ever feel like, oh, should I put it in? Maybe they won't approve it. Those things, they have no choice but to approve it, as long as you provide them enough additional details in the columns that you can write things in. overtime claiming tips. Remember to save patient details, so patient names and MRNs, because they'll want those details when you're claiming it. There is a function, if I go back in the next screen, so you can either see it on the top right-hand corner, you can either save for later or submit for validation. Essentially, every time you click submit for validation, it's going to send out an email to the head of your department for them to be like, yes or no, or well, yes, or give me more information, I want something more. So what you can do a lot of the time, instead of sending them an email at the end of every day being like, hey, approve my overtime, what you can do is say for a week or 2 weeks, you can just save up your overtime claims for each day, and then you can submit it as one lot, and it's a bit easier for them as well. And it doesn't look like you're claiming overtime a lot. So overtime claims are also, I'm pretty sure, reviewed by the heads of departments and not individual consultants. So you will come across individual consultants that seem like they are a bit against you claiming overtime. Doesn't matter if you're working, if you're coming in early or staying back late, there's a reason you're doing it, and you might as well get paid for it. And remember to let your DPETs know and escalate appropriately if there's any difficulties claiming overtime. They're usually pretty good with that nowadays. Okay, that's the end of my one. Does anyone have any questions?
So there doesn't appear to be any questions, probably because that was super comprehensive. Thanks for that, Ankita. I would now like to welcome Bongiorno to talk about transition from study to workplace and all of the things that you need to know for that.
Hi guys, hi, thank you Damesh. Can you guys see me okay? Yeah, all right, let me just get this up. Okay, can you see the screen?
Yep.
Okay, great. Okay, so who are Bongiornos and what can we do for you? So we're a financial services firm that specializes in medical and dental professionals only. And the 4 main areas that we can offer assistance with is going to be tax and accounting. So mainly that is going to be income tax, ABN, GST registration and compliance with the tax office. Another area is financial planning and superannuation. So down the track at some point, you might want to consider investments in shares or managed funds or reviewing your superannuation fund as well. So we can help you with that. Risk insurance, so this is personal insurance, so income protection, life insurance, business expense, trauma, TPD, all those personal insurances we can help you with. So we've got a department that looks after that for our clients. Loans and finance, so if you're looking at purchasing a property to live in or a rental property, we can help you with that as well. So we can help you organise finance for that. So before I go on though, I will make a note that any advice provided today is just general advice. So what that means is we haven't taken into account your personal situation. So if you do want to discuss your personal situation in more detail, just get in touch with us. Okay, so actually, let me do it this way. Yeah. So what does it mean for you once you start working? So as you can see on the table there, if you're on a salary of 70,000, this doesn't necessarily mean that all of your 70,000 will be taxed at 32.5%. All it means is that any amount above the 45,000 up until 70,000 is taxed at 32.5%. So the Australian tax system is a tiered tax system. So the first 18,200, there's no tax on that. And the next 18,200 to 45,000, there's tax at 19%, plus a 2% Medicare levy. So everyone who is working that earns over 22,000 has to pay the Medicare levy, and this is mandatory for everybody. Same with help repayments. So the more you earn, the more you have to pay in repayments. Again, this is all going to be dependent at the end of the year when we do your tax return. So if you have a lot of deductions, it might actually push you down to a different bracket and you might pay less help repayments in the end. Okay, salary packaging. So a lot of you have heard about salary packaging and probably wondering what it is. Basically, what it is as you work in the hospital, they allow you to salary package or effectively tax deduct $9,000 of personal expenses. So I'll go through an example here. Let's say you're on a salary of 65,000. If you weren't salary packaging, you would have to pay tax on 65. If you were salary packaging, then the 9,000 that you can salary package will come off that. The hospital will charge you an admin fee. And if you are in New South Wales Health next year, the hospital will take half of your tax saving as well. So any of you that are going interstate, you will actually get to keep all of your tax saving. So the difference here is going to be, rather than paying tax on 65, you're paying tax on 54. And a net saving is probably going to be about $1,500 because the hospital is going to take out $1,500 as a tax saving. Meals and entertainment. The other thing you also can claim is meals and entertainment of $2,650. So there's going to be two ways you can claim this. You can either claim this as a meal card. So at orientation next year, the hospital and salary packaging will explain to you how meals and entertainment works. And if you were to do the meal card, you nominate an amount to go on the meal card every fortnight, and you just use that card like a credit card when you go out to eat. There are some conditions. So basically it has to be 2 people, it has to be a sit down meal, and it has to be more than $15. So no takeaway, you can't dine by yourself, that isn't counted. Tax deductions. So seeing as you're going to be lodging a tax return, the ATO likes to see receipts. And the best way to keep track of receipts is an app called Receipt Bank. If you are a client of ours, we wear the cost of that subscription and we add you on as a user. You can use credit cards. However, if the credit card, for example, says APRA or Avant or MDA or anything like that, then it's pretty obvious that you're paying for a medical expense. If the credit card just says JB Hi-Fi, but you went and bought a laptop for $3,000, it's going to be pretty hard to prove that the $3,000 on the credit card was for the laptop, because it could easily be for a TV or something else. So ideally, if you have the receipt for those sorts of things, it's best to keep them. Now, Receipt Bank, how that works is if you take a photo of the receipt or you email that receipt to your Receipt Bank email address, it'll pick up the date, the amount, and who you paid. And basically, at the end of the year, all the information's there, we don't forget anything. And secondly, if the ATO was to come and do an audit, all the receipts are there already. So it just makes it a lot easier and a lot more seamless. Motor vehicle, the only trips you can claim for your car is going to be to and from, sorry, the trips you can't claim are to and from work. The trips you can claim is going to be from work to work. So if you have to travel between 2 places of work, we can claim that. If you're driving to a course or a conference, study groups, on-call trips, the only on-call trips you can claim are going to be the trips where someone at the hospital has called you and said, look, this patient has presented like this, and you instruct the person that's called you to run this test, do all these different things so that by the time you get to the hospital, you can do what you need to do. Generally, this doesn't really happen for an internal resident or even reg, so probably a bit further down the track. That would start happening. So for an intern and resident, I would say most of your car trips are going to be either work to work, or if you're driving to study groups or training and meetings as well. One of the biggest expenses that doctors in training are going to have is going to be your courses and conferences. So if you think about when you go to a course or conference, all the expenses you incur the moment you leave home to the moment you come back are going to be tax deductible. So if you caught a cab to the airport, airfares because the course was interstate, accommodation for the nights of the course, food and travel for the days of the course, we can claim all that as well. Again, if you keep receipts for that, that'll make the claim a lot easier. If you are going interstate or overseas, then ideally if you had a credit card and all the expenses on the days that you were there for the course or conference, we can pick that up. So if it was, say, from the 1st of May to the 5th of May, at least we know all the expenses you spent on the 1st to the 5th of May, we can claim those. Subscriptions, so your APRA, college fees, RMOA, medical defence, a lot of them are free for interns, but at some point, if you do need to pay them, then we can claim that. Books, journals, medical articles. So any expenses for your self-education, we can claim that as well. Computers, laptops, USB cables, printers, software, we'll be able to claim all that. We don't claim any of these 100% because there's always going to be some private use associated with it. So that's again something that the ATO would be looking at as well. Stethoscopes, if you need to buy a new one, we can claim that. If you need to fix or repair any old iPads, laptops or computers, we can claim those as well. So income protection, most of you will get this at some point. Again, it's not a matter of if, but more it's when. Usually there are trigger points for when our clients take that up. And usually it's either going to be when they're taking on a mortgage, or there are a lot of income protection changes coming up as well. So they kind of want to get in before those changes happen next year. And also if they have dependents. So there are some trigger points that will prompt you to get that. Printing, stationery, postage, scrubs. If you need to buy any scrubs, we can claim that. If you need to buy any new clothes for work, we can't claim that. So the thing to remember with that is if you wear it out in the street and the general public cannot tell that you are a doctor or you are working in the hospital, then we can't claim it. So if you're wearing scrubs out in the street, it's very easy to see that you work in the hospital. It will say New South Wales Health on the side. Whereas if you're wearing Aaron Williams shoes or if you're wearing like a nice suit or anything like that, no one's going to know what you do. So those type of expenses we can't claim. Mobile phone. So what you'll find is you'll actually start using your phone a lot while you're in the hospital system. Depending, you're probably not going to go and find a work phone at the hospital every single time you get paged. So you're just going to use your phone. Again, we would claim a portion of that as well. And the best way to do that is if you have a phone bill, you highlight all the work calls and we would claim a percentage of that over the total bill at the end of the year. You only need to keep that for a month. Private health insurance. So there are two trigger points for private health insurance. And one of them is if your income is over $90,000 and you don't have private health insurance with hospital cover, you will pay an extra Medicare levy surcharge, which is basically extra tax you're paying to the taxman. The other trigger point is not tax related, but more premium related. So if you're over the age of 30 and you have never had private health insurance with hospital cover, then they will add a levy onto the premium. So let's say you decide to take out the cover when you're 35 and between the ages of 30 and 35, you never held private health insurance with hospital cover, then for those 5 years, they'll do some calculation and they'll add a levy onto that, onto your premium when you take it out. So just very quickly, some financial planning tips. Classic example, we've got some debt and we also have some savings as well. What would be the best way to go about that? So you can see there, if you had some interest income, you'd have to pay tax on that. If you had some debt, you have to pay some interest on that debt. So at the end of the day, you're really not saving much. So it's probably better just to pay that debt off. Buying your first home, so we can help you organise a loan for 95% of the value of the property, which means you only need a 5% deposit. If you are not utilising any of the first homeowners grants, then you'll probably need another 5% for stamp duty and also legal fees as well. And that is pretty much it. Let me just get out of that. Is there any questions? Does anyone have any questions? No? Okay, I think we're going to send these slides around as well. So if you guys do have any questions or anything, just sing out. We also offer advice and tax returns free for interns. So we look after our interns for free. So that's tax return and if you need us for anything throughout the year as well. Thank you. Thanks, Somesh. Thank you.
Thanks so much for that.
That's okay.
So the next speaker is going to be Vinay, who's going to be presenting on how to do a handover, just some tips on that, as well as some of the other things you can do at hospital whilst you're doing your internship. So come on out, Ben.
Hey everyone, let me just see if I can navigate this screen business. Yeah, screen, share. And it was, there was that hint, I can't do it. Okay, I think it should be fine. I've got my notes here as well. Okay, sweet. So you guys can see, I think, just the title slide. Is that right at the moment?
Yep.
Sweet, awesome. Hi everyone, hope you're having a good night. So as Dr. said before, I'm going to be presenting on like 3 aspects today. One is like presenting patients in general handover. The second is extracurricular activities in hospital. And then the third is maybe just like a general approach to your like internship year from a learning perspective. And yeah, so there'll be time for questions at the end, but if you have any questions as we're going through, please feel free to comment in the chat and then I'll look at the end, or yeah, use your mic and just like speak up, that's fine. Great, so probably I guess the thing to understand is, why really is, clinical communication important in the hospital, and why is it a good skill to be able to present patients and do handover? This is a little background. I was always really bad at it as a medical student, and I find it quite anxiety inducing. Because you're basically trying to get someone interested in what you're saying in a really short period of time, and you're also asking them for help. So you're kind of, it felt like you were taking a lot of from that person, but really what the aim of clinical handover and communication is to ensure almost like a seamless transition between the care that you're providing for a patient and then making sure that it's continuing on with some other individual or some other team. Okay, and that can be in a wide range of settings. Okay, used in almost every aspect of medicine when you're talking from one clinician to another, or one healthcare worker to another. So it could be whether you're just ordering an investigation and you're calling the CT reg and saying why you need a CT abdo for a patient who you think has acute diverticulitis, or if you're consulting an endocrinology team to find out, what's the management plan for a patient with severely deranged blood glucose levels. If you're presenting a case in ED, which is probably the point where you may get the most amount of practice, depending on how your shifts are. But you may be talking to an ED consultant about a patient you've just seen, and you're presenting your findings before you can develop a provisional plan with them. Handover meetings is another type of form of clinical communication. And for me, I found that it differed somewhat to the way in which I would do or the template that I would use basically, compared to if it was, all of the other situations above. And then there are some other types of clinical communication that's important to start to master. And those would be discharge summaries as well, because really what you're doing there is you're kind of closing the loop with the patient's GP and ensuring that any plans that you've created during hospital that's necessary for the patient to, get the best care possible once they've left the hospital, are fulfilled. So that's really important there. And I guess there you need to start thinking about from a third person perspective, someone who's never seen the patient while they've been there in that presentation at hospital, and it needs to make sense at that point in time for them. And then discussing patients with on-call registrars during your after-hour shift. And that can be a little bit scary sometimes, because typically it's someone maybe you haven't really had much relationship with, and you may feel isolated on your after-hour shift. But my experience has been, for the most part, that it's relatively, the people are oftentimes, they're a little bit busy, but at their heart, they're still nice. And so I think keeping that in your mind, that the fact that most people aren't really mean, should make things easier. But underpinning it at the end really is just that you're trying to maintain patients' healthcare in the best way possible throughout their journey in the hospital. Okay. So I guess the question is, how do you hand over? And there are multiple different templates and acronyms that are used, and probably the one that's used most commonly, and you've probably heard this as well in the New South Wales health system, is ISBAR. Now, ISBAR is really great. It's good to have to understand kind of the codes of communication that you'll be using and that other people will be using, because not only is it an inherently logical system for you to provide information, but it's also a template by which someone else is going to be listening to your information, hearing for the different components of it, which we'll go through in a moment. And so that's helpful as well. Okay. So what does ISBAR mean? Okay, so I is an introduction, and it's as much an introduction about who you are, which is your name, what your position is and where you are located. So I'd say, hi, I'm Vinay, I'm the urology JMO, and I'm just calling from 5E. And then you also want to clarify who you're talking to. So sometimes someone else is going to carry the pager for, the vascular consults pager on that day, or maybe someone's in theatre and one of the theatre nurses is going to pick up the phone. So always clarify who you're talking to before you launch into your spiel, so that you're not wasting time and you're not wasting your own time or the other person's time, and you're like more directly talking to the subject matter. The second part is S, the situation. So basically what you want to give here is just a brief summary of the clinical situation. And that includes the patient, okay? So you want their details, so their name, their age, their gender, and maybe the diagnosis, so why they're in hospital. So, it could be Terry White, who's a 64-year-old man who's come in with an excessive exacerbation of COPD. Their status, that's really important as well. Is this a stable patient, which might tell the person on the other side of the phone, okay, this is something that probably doesn't as much of a quick response compared to someone who's unstable as well, or versus someone who's actively deteriorating at one point in time. If you're actually concerned about the patient, that's part of your assessment. That's part of the situation. This is an urgent situation. And I think you should tell that to the person at this point, because it probably makes them, probably listen a little bit more carefully, and maybe think more sharply about what's going on. And they'll start to, the cogs will start turning in their heads as well. And then stating the purpose at the beginning of the conversation is good. Some people will say that at the end, and they'll do like this R part with recommendation or / request. I think it's good in the beginning if you can say why you want, why you're talking to this person. So is it for takeover of management? Is it for sharing of management? Is it for referring someone for a particular investigation, or just some advice, or to tell someone that someone's actively deteriorating? So let them know at the beginning of the conversation, because it frames the way they're going to start interpreting your background and your assessment. So we've gone through introduction and situation. The third part is background. So I guess you can kind of split it up into two parts. Is it a really urgent situation, in which case you can kind of do your famous ABCDE approach. You can just say, what's the acute issue? So you can say, I've got a guy who's a massive PR bleeder right now. This is his ABCDE, or that can even form part of your assessment if you're going to go through it really quickly. But if you're not calling for something, if you're just calling a consult on the ward, maybe for a patient who's had, a solitary lung nodule, and you want them to be followed up by respiratory, or just get a consult, maybe you can go into more of their history. But you always want to have the pertinent details. And on the next slide, in 2 slides later, actually, I've just got a little kind of cheat sheet that's done the rounds on the internet quite a lot about some details that different specialties would like you to have on hand before you consult them. And that can also be useful, not just for consults, but just if you're talking about an issue at a handover to a general medical team, maybe those details would be useful, because they will also be things that you would want to know about a patient with a particular issue. So have some brief and pertinent details on hand. The things you would really want is, what is the history of the patient relevant to the, a problem at this point? So if it's deranged blood glucose levels, you'd probably want to be telling them what type of diabetes, when were they diagnosed, what sort of therapy are they on, what's their control of their blood sugars, macro and microvascular complications, for example. You'd want to be looking at your exam. So, does the patient really demonstrate, florid hypoglycemia, and are they really symptomatic of it? Okay. Or is it something that's a little bit more subclinical, but they just tend to have high BSLs? What investigations have been done at that point? Okay. So, what's the BSLs been today? Have they had any ketones done? Do they have an HbA1c while they were in hospital? If you're thinking about DKA, do you have any relevant investigations like a blood gas that can back you up on that? Okay, and then treatments given so far can sometimes is also good at this point here. Maybe if a patient has failed response to an initial treatment, that's part of their background, because it's part of the history at that point. Okay, and so you would say, I've tried, if it's after hours and you're talking to your after hours registrar about a patient whose blood glucose you weren't able to bring down, then you might be able to say that, I've given the patient initially 4 units and then I gave another 4 units, but they're still quite hypoglycemic. I'm not sure what to do. That gives them an idea that you've kind of thought through, things have been already initiated, but we're at maybe like the second line of treatment at this point. So that's B for background. In my opinion, it's probably the hardest part because you really want to summarize the pertinent details of the case in a way that sells it and makes it interesting to the person on the other side of the phone and it kind of gets their interest. So that can be the tricky part. And I think practicing is obviously going to make it better. I think if you can put yourselves in the shoes of the person on the other end of the phone and think, what do they want from me? Then that makes it easier. And what would change the management of the patient? What details are going to? And then your assessment is basically just what you think is going on. So it's kind of like a provisional diagnosis. I think this patient's got DKA, or I think this patient's post-op and they're rebleeding now. Or I think this guy's having a stroke. So you can say that. And if you're unsure, say that. That's totally okay. Uncertainty in medicine is like pandemic. It's everywhere. So it's not bad for you to be unsure. And also as interns, we're not meant to be at the peak of our clinical knowledge. So we're still, trainees. We're still young people that are learning. So that's okay. State whatever you think is obvious as well at this point. So you can say that if it's very clear that there's a clear-cut diagnosis, state it, but also state your uncertainty. And then the R part is just a request or recommendation. So, what do you want the person to do? Like, I would like you to come see this patient because I'm concerned of the above, I just need some advice about what's the best next management, or well, I'm not sure what to do for the next investigation, or do you think this is the appropriate test? So you can start with the question as part of your situation, and you can also end with the question as part at the end. And that kind of gives a nice bracket because it reminds the person, it frames the person who's listening to their thinking at the beginning. And at the end, it also helps them to like put everything back into context and think, okay, so that's why I've been called. Okay, so that's ISBAR. So introduction of yourself and the person, situation, why you're kind of calling them, and like just a brief summary of the clinical situation. Background is the pertinent details of the patient. Your assessment is what you think is going on, and the R is the request, what you want them to do, or the recommendation. So sometimes you haven't done anything for the patient yet, but I should have said this earlier. Sometimes you may have a provisional plan in place and you kind of want to get it approved, and so you'll do that as part of your R. Now, if we have different circumstances that I said before, whether it's ordering investigations or doing a consult, or you're at a handover meeting after hours when you just finished your shift. But before you present your patients, there are certain things that I like to do that I thought helped me present a little bit better. So a couple of things would be have the EMR page open, or if it's paper notes, have the paper notes in front of you. If there are any outpatient investigations, have those in front of you. Because sometimes they could be really important, especially when you're in ED, you're not going to have the outpatient investigations on the screen, but you need to have them in front of you. And then if you've typed up in a little investigation, a little assessment of the patient, like your ED case history notes, or if it was a clinical review, if you have those notes up in front of you, that's great. Because it's basically the same, like your history, exam, investigations, impression, and provisional plan is kind of the way that you're going to be presenting your background part, okay, and your assessment. And then also your recommendation. So you've kind of already done half the work if you've documented and you've had time to document before you talk to someone over the phone, or even in person as well. Now, I don't really need to memorize what you're going to say to the person before. But I found that when I was in ED, and this was my first term, it was really nerve-wracking to have to call a consultant after hours and convince them that this call was important. And so for me, I wrote down my whole consult and I just said it verbatim. And I found that calmed me down a lot. And then I think as you get practice doing it like that, you can maybe transition into just doing it kind of free flow and just based off whatever your notes are or what you remember from your, like what you have from your memory. Okay. So that's just a little tip. It just depends on who you are as a person. Before presenting, I always would like to ask myself the question again and remind myself, why am I actually calling? And then if you have any doubts about your story, just like think through quickly. like the patient's maybe had a seizure and you forgot to ask them were there any witnesses, or you forgot to ask them are they on any anti-epileptics. Just quickly go back and check with the patient and then come back, okay? It's good to just have as much of the details as you can first. And then I'll just show you the cheat sheet in the next slide. And the other good thing is always have something to document. Like sometimes they'll rattle off a plan and like they'll list 20 blood tests that you need to do if it's like some weird like gastro liver screen thing. And then if that's the case, you want to be able to type something up or write it down. Okay, so have something on hand. Now, this is what I was telling you about before. I've used it a couple of times and I found it useful because sometimes I just won't remember things that I needed to talk about. And so that was good. It'll be part of the slides, and I think I can just email the slides to Dharmesh later on, and then he can circulate it with you guys, and it's also being recorded, so it's up here. But if you want a copy, yeah, it'll be in the slides. And then, yeah, so it also just has like a little thing on the left-hand upper column side, what to do before you call and like some opening lines. So that can be a little bit useful as well. Great. So, like during the presentation, be calm, breathe, think, keep the question in your mind for the whole time, because that's going to help tailor whatever you're saying in terms of your background, which is the tricky part, right? So yeah, and you know, if the other person is not talking, that's fine. If they're yeah, like that's also fine. That's just like the way the person talks. And if they cut you off in the middle, don't freak out. That's okay. You know, sometimes people are in a rush or they have really specific interests when they are when they're listening to a story and they want you to get to the point or get to, you know, the parts that they find interesting. So don't be put off by that. It's just their way of kind of tailoring what you've done as a nice extensive presentation. Okay. Sorry, I'm just going to turn the lights on. Sorry. So don't be too put off by that if during the presentation they do cut you off. It's not them being rude. It's just them trying to get like the best out of you, essentially. Now, after the presentation, if it isn't an emergency, then document quickly because you don't want to forget anything that's been said if there was extra stuff. If it's obviously you won't have to document, but otherwise use your notes from what you were doing during just to enact your plan. Now, always at the end of just after you finish presenting, at the end of the call, what I like to do is just reiterate with the person on the other end, or even if it's face-to-face as well, just with the person, just say, look, I just want to make sure that I understand the plan. We need to do A, B, C, D, E. And they're like, yeah, sure, but also don't forget F. And that's great because that closes the loop in a way, and it means that you and them are both on the same page. Your documentation, if you both document, is going to be consistent, and that prevents there being any misses for the patient's care, and ultimately makes you more of a safe doctor, which is what you want to be. And what everyone expects you to be, as opposed to like this ridiculously smart person. It's just more about being safe. Now, I won't talk too much about it, but sometimes, you know, the outcome of what your conversation on the phone or in face-to-face, or when you've handed over a patient and there's a disagreement, it may not be what you want for the patient or what you think is appropriate, in which case you may need to escalate. I think Anu has a slide on it, and I think she may be talking about it later on. So I won't go into it too much, but always I would encourage you to escalate when you're concerned about patient safety. And remember that if you're doing something in the name of patient safety, no one's ever going to question you. And if they do, you know, it's a really temporary discomfort for a long-term gain, or at least confidence that the patient is safe. And I think at the end of the day, you want your patient to be safe. So yeah, awesome. Now, I do a slightly different kind of template when I go to a handover and I'm talking about a patient. And I use a thing called iPass, which I found a little bit more useful in terms of handing over the patient, really. So I would say how sick the patient is first. Do you really need to watch over the patient overnight, or is it someone who you can just kind of like just be aware of them? Okay. Then the patient summary, which is, you know, what's happened during my shift that makes me want to hand this patient over. Like, okay, the patient developed chest pain, they had DSATs, and they did a CTPA, and they've got a PE. Okay, and maybe that just happened in the past 10 minutes. So you may want to tell them that. Your action list is basically what you're telling them that they need to do. So that's really important, because if you say that you need to call, or like the patient, you know, respiratory said they're going to get back, can you please chase them because they're unsure what anticoagulation to start the patient on. And it's important that the patient gets started on anticoagulation. So that would be one of the action list items. And you can have multiple things there, but also always state who has to do things. So at a handover, you want to be clear, is it the med reg, is it surg reg, that typically don't attend at my hospital, but is it med reg, is it the JMO, is it the ICU nurse who needs to do it, okay? And then S, the first one is contingency planning, basically. So, if the patient desaturates, then you need to do this, or we're going to do a repeat gas, and if that repeat gas shows blah, 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 you're going to, the plan is for this. So always let the team know, the team is being handed over to, what's the possibilities and what your aim for those possibilities are, as well as the patient's resuscitation status. That's really important, I guess, like especially for your elderly patients, it's good to know so that you don't accidentally start, going like crazy on their ribs, okay? And then the IS is just census. So just maybe touch base with the person and say, is this like, does that make sense? Do you have any questions? And just a way for you guys to touch base. So IPASS, there's a little summary there of how IPASS could work with like this fake patient, Susan Williams. So you can have a look at that when you get the slides circulated as well. But it's very similar to ISBA. I just find that it's a good way of, if you're writing a handover sheet down, then you can structure it like that. Okay. So this is, any questions about, I can't see for some reason, but any questions about, no? No questions so far? Cool, awesome. Right, sorry. There we go, sweet. Extracurricular activities. So it's really fun. Okay, so as much as, and I think Shakif was mentioning it before, and I would like to echo what he said. There's so much stuff that you could do in the hospital and outside the hospital as well, in terms of furthering your career or upskilling yourself or just becoming a better doctor. It's not that to say that becoming a better doctor isn't important, but your mental well-being is also really important, and it's good that you enjoy yourself and enjoy your life, so that when you're at work you're a happy person, and that you're able to probably give your 100% to your job. That being said, if you're someone who really finds value and you enjoy it, getting involved with different activities, then you should definitely go ahead with it. Hospitals offer quite a lot of stuff, which is really cool. Teaching, obviously, you've probably had teaching done by JMOs this year, and it's a good way for you to consolidate your knowledge, give back to the student body from which you came as well, and it's a good learning opportunity for you. Research is really easy to get involved in most of the time. If you just find, a field that you're interested in, you can message your AT or a consultant sometimes, and often they'll have some project which you can get involved from a data collection point of view, or if it's an audit. So something like that, they're quite easy to come by. If you have an idea for a project, that's really cool. Just express it to someone, and I'm sure if you're really passionate about something, they'll take on your idea and something that's even better and you didn't think of before. Committees are great as well if you're interested in kind of getting involved with quality improvement and rostering as well. And they can be interesting because you have experiences around the hospital with maybe issues and you want to see them to get better, and you work with these committees and you see changes actually happen, and that can be like deeply satisfying. So if you like that sort of stuff, then get involved. The caveat, I guess, with committees of research and teaching in hospitals, and I'll talk about representatives in a sec, is that they do have a bit of time commitment, and you're working in a team, so people will be depending on you. If you think that you're not able to meet those time commitments just with anything, then it's probably best, even though you're really interested, maybe not to subscribe for it just at that point, and maybe wait until your time management is a little bit better, or you're able to give it the time that you want and the time that it deserves as well, so that the projects continue on well. There are heaps of courses that you can do, whether they're ALS courses, or some people are really interested in imaging, so ultrasound courses, or I think Shakif was talking about I can't remember what the new name is, but like the Diploma in Child Health as well. And then, so get involved with those if you're really interested and you want to upskill, because there's so much that you can learn and do as well. Representatives, there are a lot of external bodies. I think some of the people here are involved with HETI. So that's one thing they got involved with this year, which has been quite rewarding and fun. And it's good to work with people around New South Wales and look at ways of improving training for New South Wales doctors as well. So yeah, there are lots of things that you can do. Just budget your time and make sure that it's not detracting away from your well-being as well if you're doing it for reasons that are like purely for career and not because you enjoy it. And the last thing, which is a little bit fluffy, but I think it's really important for me at least, was how should you approach internship? And for me, internship was basically like a fruition of medical school, where in a more direct way, you're basically afforded the chance to apply the knowledge and skills you've been learning for the past 5 years. But the thing is, like, medical education isn't consistent, right? Like every single person here is going to have a different experience and different skill set. But you enter this vast sea of medicine in the hospital, and you're equipped with like different knowledge and different skills in the hope that you float. So I started my year in ED, and I was constantly presented with patients who had things that I just didn't want to see. Like I found it very confronting and hard to deal with ONG because I had very poor ONG knowledge. And I progressively realized that, and I thought, okay, I just have to start seeing these patients, and I did. So there's a little bit of self-reflection there. I knew that I started to gravitate maybe like more towards neuro patients because I really enjoyed it. And I really liked some of the surgical patients, so I started going towards that. And that meant I would start to frame my own learning experiences in a way so that I was going towards areas that were maybe less comfortable, because if the internship is meant to be a period of growth, that's only going to come from periods of like, commensurate uncomfortableness, basically. And I think that's okay, because you have this period of uncomfortableness, and as long as you have like a good support around you, then you'll come out of it better. So I guess self-reflect gently on maybe like lists of topics and skills that maybe you're confident with and that you want more experience with. And this can always include softer skills. Like it doesn't have to be that you want to learn about AKI and electrolyte derangements, but you may also want to learn about how to be a better team member on a ward round, or how can you develop an effective handover list. So keeping that in mind, I think if you can be self-aware of like those things, but then also self-aware of your health and your well-being, then you can have quite a fun internship, and you can come out of it feeling like you've achieved something, both for the hospital because you're providing better care for patients, but also for yourself because you're a lot more competent, you're a lot more strong, and you can like kind of track your own journey, which is great. I hope you enjoy internship. It's really, really fun. It's a little bit stressful at times, but I found that even though it's been uncomfortable and tricky, at the other end, there's always been a lot of growth and probably like a better Vinay, which has been fun. So yeah, I hope you guys all enjoy it. And yeah, all the best.
Thanks so much, Vinay. And we might just quickly move on from there. So we've got Peter and Alex from BOQ. So could you please welcome them?
Thanks for having me today, guys. It's just me. Unfortunately, Alex couldn't make it. So before I start, I should share my screen and the presentation. Now, yeah, congratulations, guys, for getting to finish all of your studies. Now, it's a great achievement. You should all be very proud. I'm sure it felt like 5 long years, especially this last one with the mess that it's been, but you've gotten through it. So you now can look forward to your internship next year and actually earning some money. So congratulations. Now, I should probably not start at the end of my presentation. So let's go back a bit here. Beautiful. So now, before I get into it, so I'm just going to go through what a BOQ specialist provide and do, some of the facilities that we can offer yourselves now and in the future. And yeah, we'll take it from there. Before we get into it, the slides are equipped with QR codes. We're a bit technologically advanced here now, which is good. So feel free to scan your phone if you see anything that is interesting and you do, would like some further information on, and that will lead to a link, and there'll be more information on our website with regards to the specific slide that you are interested in. So yeah, make sure you go through that. So BOQ specialist, what we do. We are basically a financial provider. We assist solely doctors and dentists. That's our specialty. We understand your whole career life cycle. So we understand what you go through when you're students. We understand what you go through when you first start your internship, all the way throughout your career. So we provide facilities that are tailored towards your needs. So, you know, currently as final year students and then going into as internships, going into your internship rather, we provide transactional facilities, bank accounts, also a car loan. As you sort of get older, like next year, we can start looking at home loans and so forth as well. And even, you know, years down the track, we actually provide commercial property, you know, commercial and practice finance and so forth as well. So that's our specialty. That's all we do. We are part of Bank of Queensland. Now, we are proud to be a sustainable lender. Whilst we are, I think 0.1% of our book is currently invested in fossil fuel and or mining projects, but by 2023, we're going to be fully divested out of that. So it's something that our CEO was really important to him when he didn't announce that a couple of years ago. So we're not too far away from that now. And yeah, it's something to be proud of. I think it's very important that we are on that right track. And yeah, so that is our plan for the future. So I'm going to go to one of the facilities that we provide. So yeah, so one of our bank accounts that we do provide is what we call the One Account. Now with the One Account, you'll get all your standard features like your debit card, you'll have paywave features and all as well. Now the big key interest that you may have heard of is what we call an overdraft. So the overdraft is what sits alongside your bank account. So yeah, as I said, you'll have a bank account that operates as per normal. The additional facility is called an overdraft, and it gives you the ability to go below zero should you need it. So as what we call graduates or career starters is what the package is called, you are eligible for a $15,000 overdraft. You don't have to take out that full amount, but you do have the option of accessing those funds should you need it. So as I said, it gives you the ability to go below zero should you require it. If you don't go below zero, you don't pay any interest. It just sits there idle in case of emergency. So we've got this slide here that does explain it a bit better. So if you were to go below zero onto the blue arrow, for example, the interest rate applicable to yourselves is 7.04. That's a reduced rate. Usually overdrafts are a bit higher. Usually it's around 10%. So that is a reduced rate for students and is applicable all the way through to 6 months of your internship next year. Also, one of the other perks that we do have with the overdraft, usually you need to maintain them and service them each month. You don't have to make any contributions until, again, 6 months into your internship. So as I said before, we tailor the products so they are like convenient for yourselves. We understand you're not going to be earning any money until next year. Your first pay stub will come through in February. And then by the time July hits, hopefully you will be on your feet financially. You do have a steady income and then can start paying that overdraft back. Lastly, before I move on to the next slide, you can see the orange arrow there as well. That is with regards to any savings you may have. Now, usually your standard everyday account won't earn any interest on your savings. However, our account, we give you a bonus of 1%. So it's 1.25. And again, that's applicable all the way up to 6 months into your internship, should you have the money to put away currently. So the next facility that we do provide you currently is what we call a credit card. So I'm sure you've all heard how a credit card works. The big thing to keep in mind when you do use a credit card is, unlike the overdraft, where interest is applicable as soon as you do use it, a credit card has an interest-free period. It can be up to 55 days interest-free. So credit cards are brilliant if you do maintain them within that interest-free period. If you go over that, then you do start incurring interest, and it's a lot higher than the overdraft accounts. So make sure you do service any transactions on the credit card. Sometimes even people use their overdraft to pay that off because at least the overdraft has a lower rate. So that's something to keep in mind. Now, both facilities with the overdraft, usually there's a $445 fee. We waive that seeing that you're a student. Same with the credit card. We actually waive the fee for the first 5 years. Usually it's $150 for yourselves. We waive that for the first 5 years. So yeah, that basically gives you the opportunity to use that for, you know, however long, and you know, in 5 years down the track, you may want to upgrade to a better card. This one does earn points depending on your spend. Now, obviously we can't fly to a lot of places currently, but you know, you may be able to save up those points now and then spend them when we actually can fly to places. For every $2 you spend, you get 1 point. And any overseas spending, you get 1 for 1. Again, may not be able to do that just yet, but hopefully not too far away, we can start to travel. Lastly, with the credit card also, if you do book your flights on that card, you get your travel insurance included as well. And like all of our facilities, you get 24/7 customer service access. They're accessible whenever you need them. You'll also get access to a private banker like myself, where, you know, if you do have any issues that you're hoping to get solved, you always have us as a contact. So other facilities that we do provide you currently, we do now offer for final year students looking to start their internship next year, we do now provide car finance. So usually we can go up to around $30,000 for a car purchase, should you need that much. We also tailor that so you don't have to pay any, or you don't have any repayments until 3 months into the loan. So that usually gets you to February, when you are getting paid. So again, we do tailor that so it is convenient for yourselves. We understand that you're still probably a bit cash poor until you start, you do get that first pay slip next year. We can also tailor the structure of the loan depending on what you prefer. So we can go from, a term of 2 years, 3 years, 4 years and up, depending on what you prefer. Some people usually go for around 4 or 5 years. And again, after 5 years, you may want to sell that car or just roll that contract into a new one. So you do have that option. Lastly, and it may seem like it's a bit far off, but you'd be surprised, depending on where you do plan on buying, but home loans will be available to yourselves once you do get your first, when you get your first pay slip next year. We can start actually looking to approve a home loan for yourselves. Now, we can even start having the chat before that, but yeah, the approval won't be able to come through until February next year. But like, it's something to keep in mind now. Some of the questions that you will, want to ask when it does, when the question does come up is like how much you can borrow. So we can always look at your borrowing capacity depending on how much you're earning. Now, it'll be based on your base salary at the start, but a few months in, we'll be able to consider overtime as well. With regards to if you need a deposit, in some instances, we can go up to 100%. 95 is also possible. It all depends on a case-by-case basis, but it is definitely possible. So even if you don't have a large deposit, you still can get into that market. And as you can see from the last the last question there, with regards to renting versus having repayments, we can have a conversation about that as well. So some of the perks with our home loans, you don't pay any lender's mortgage insurance, even if you were to get 100% lend. So that's a massive saving when it comes to the whole loan process. As I said before, home loans can be quite daunting, but we try to take all of that out of it for you. We try to explain it all, how it all works, so it's not too confusing. Banking package. So yeah, we do include additional facilities with the home loan, which is an offset account, as well as a credit card. Again, with this facility, you'll get access to a private banker like myself, along with our client services team that are, as I said before, 24/7. So that's about it. I believe that don't bother scanning that code, because I think Damesh is going to draw that for us, but there is a $100 Visa voucher that is available this evening. So he'll let me know once it has been drawn, and we'll be in contact with the lucky winner. Now, if you've got any questions, I don't think we've probably got time today, but feel free to scan that top code there. That will lead to my contact details, or even just take a photo of that email address and phone number. If you do have any questions at all with regards to what we've chatted about this evening, just let me know. But thanks again. All the best for next year, and thanks for having me.
Thanks so much, Peter. And so that $100 gift card is also available for a prize for this form that I've put out in the 5th year group.
Beautiful. Cheers.
Thanks for that. And so moving on, so we've got Up next, Anu, who's going to be talking about helpful apps and resources for internship, as well as some time management and mental health strategies. So please welcome Anu.
Oh, hi everyone. Let me just try and screen share. Can everyone see this?
Yeah.
Awesome. Okay. This is just like a few quick pointers on internship. So first of all, a huge congratulations to everyone. You guys should be very proud of yourself, particularly with all the challenges with COVID, and making it this far is amazing. I know you guys must be feeling quite scared about internship, and I certainly was, and so is everyone pretty much who starts. But just like in point of advice is you're not alone. So there are always ways to like seek help, and you will feel better as time goes through. So I've just sort of broken down my parts into a few tips, and some of the tips that will be covered by like that have been covered, I'll glaze over it, but I'll provide my PowerPoint. So the first one is the transition. So right when you start internship, it's a huge lifestyle change. You're working about 40 to 50 hours a week, navigating the challenges of being part of a hospital system, but also balancing everything else with life. Don't be surprised if it's not what you expected. Being a junior doctor is very different to being a medical student, even if you did start doing a lot of the things in your print term. You are much more integral as part of the team and involved in management decisions. And the hospital in its own is undergoing a huge transition. So like residents are becoming registrars are becoming ATs, medical students becoming interns. So just remember to seek support and debrief with your friends, your colleagues, mentors, and families, and that you're not alone. So number 2 would be, I guess, a typical day in the life of an intern. This does vary term to term based on whether it's surgical, medical, or emergency. So basically in surgical or medical terms, you usually arrive about 30 minutes to 1 hour early. And that really depends on like your caseload or the nature of how your day starts. You can use the mobile app to screen like how many patients you have, how many you've gotten overnight. And I think there's a way of getting PowerChart access on your computer, which I'm happy to share, but that's also dangerous. Because remember, when you clock off work, you should try and focus not on work, and make sure you also have breakfast in the morning. In terms of before the round starts, what I usually do is kind of review all the patients under my team, how they went overnight, if there were any issues after hours and any investigations, and also making sure that they have bloods ordered for the morning if they need it. Prepare a list. You can print from PowerChart, but usually that's quite condensed, or you can create your own. I'll also share an automatic list generator with Damesh, and then he can share it. So that will help create like a very beautiful table format of a list. And you can do pre-round notes. And usually in pre-round notes, you'll sort of put what the patient came in with, relevant issues and relevant investigations. I found this really useful, particularly on surgical terms when the ward rounds go really fast, but it is optional. And you notice particularly as people reach residency, you end up not really pre-rounding as much as you did in internship. In terms of the ward rounds, it's really useful to have templates on PowerCharts, and you can save templates even just for examination findings, and you can kind of edit it. The most important thing on the ward round is document what's being said, any key examination findings, and try to do as many jobs as you can on the round. So for example, if they're like, can you change them from Panadol IV to Panadol oral? You can do that online as well. Another thing is making sure you really get the plan, and never be afraid to clarify the plan, particularly on terms where there are fast ward rounds. It's really important to clarify the plan. And in surgical terms, the registrars usually go off to theatre, so it might be harder to bounce the plan off them. A few things that I guess on medical terms, I'm more aware of the issues list to make sure that we are addressing everything relevant for the patient for their best interest, and on surgical terms, diet, DVT prophylaxis, and antibiotics as well. After the ward round, I usually do all the jobs. And in the next slide, I'll show you how I prioritize jobs. And then post jobs, I usually do a self round. I review any of the new results and I order bloods for the next day. And here, this involves also communicating with a registrar if anything has gone wrong. So it could even be like texting, I noticed this person's potassium is 2.1. I've charted them some oral replacement, and that's all, just for closed loop communication. So the way I used to do, way I prioritize my jobs list is I used to divide a box into 4. So the main sort of things would be consults, investigations, discharges, and other. So investigations, I try to arrange them on the round. So for example, if they're like, can you order an ultrasound or CT or an MRI? If possible, I order on EMR on the round, but sometimes after the round, you'd need to call and just confirm with the radiology reg. For consults, 10 to 12 is the sweet spot. Usually registrars are rounding before. And like Vinay said, try to use the IPASS or ISBA acronym, and always have a clinical question. If you're really unsure why the consult is happening, it's better to try and clarify that with your registrar before. But you do often get the consults that's like, this person has hypertension, can you call renal? So a good technique that's really good for JMOs is, sorry, my consultant wanted this, even if it seemed like a bit of a soft consult. Discharges, try to prep the discharges the day before and put in medications, and that's usually to the pharmacist the day before. And usually if that happens, at least in the morning, your jobs won't be sort of disrupted with needing to write a discharge summary. Unfortunately, sometimes you may have spontaneous discharges. So it is inevitable, but remember to make sure that you prioritize patient safety before getting to the discharges as well. And other could be like updating families, faxing correspondence. If it's not urgent, that's more in the latter part of the days. And things like trying to get things faxed over, you can kind of do between patients as well, if you have time. The tip number 4, which is what I wish I knew when I started, was kind of, unless it's an arrest and the patient is hemodynamically unstable, you can take some time. So I think in like my first week, there was like a clinical review for rapid atrial fibrillation. I was so anxious. I didn't know what to do. And even theoretically, if I knew what to prescribe, I was really nervous. But I like ran and and it was like super stressful. But I realized that like having all that stress was like, I guess, invariably not as effective. It is very important to be safe and be responsive and not take too long, but it's also okay once you get to the patient, you don't need to jump in and do things. Take a breather, think, and always escalate. And I think if you're feeling uncomfortable, and if the patient meets any criteria for either a rapid response or MET call, no one will ever like question you for hitting that MET call button, particularly in the first few months as well. So tip number 5 that goes to always ask for help. Everyone is really, really nice, and no question is a silly question. So I think like never feel afraid to ask. And this includes even asking your other JMOs for help if you're really, really busy. And I think it applies the other way. I think if you're having a very chill day, help out your other JMOs, because we're all part of a team as well. And the tip number 6 was, I guess, I kind of touched upon, was don't be afraid to escalate. I think a key part of being a junior doctor is recognizing a deteriorating patient. You don't always need to know what to do, but it's good to know when to escalate. While you're waiting for help, always do simple measures. You can put in a cannula, take bloods, you can chart fluids, you can maybe order simple investigations like an X-ray, you can get an ECG done, and symptomatically manage them like analgesias, antiemetics. You can give them insulin if they're hyperglycemic, but always, I guess, recognize your own limitations and don't be afraid to sort of escalate beyond that. Tip number 7, it would be closed loop communication. I think a lot of the errors that happen in hospitals are due to communication errors. So it's always good to communicate with everyone in the team. And this is not only the doctors and the ATs, and usually the registrar is communicating with a consultant, but the nurses and the NUM end up being your best friends. So have a really good relationship with them and they can help you out so much. Document everything, all the important communications. And I always find it really good to paper around with yourself and with the team. And at the end of each term, always hand over to the incoming intern just to facilitate like smooth sort of transition between terms. Yeah, I guess that would be tips for communication. Make sure that's sort of like in the forefront of your day-to-day activities. Tip number 8 is after hours. I'll leave this to Megan because she's done a lot of work and prepared some good tips and sort of scenarios, but I'll have this slide available as well. Tip number 9 is seek feedback. You do have a midterm and end of term like HETI assessment. It really helps to ask for genuine feedback, and people are really good with that, and it really helps you grow and develop as a JMO and also beyond your career. And also just for like post term, particularly if it's a term you want to do like physician or surgery, it's okay to ask for a reference. They most of the times offer, but it's also always okay to ask, and I think that will help with the stresses around job recruitment in residency. Tip 10 would be make the most of your JMO years. I know the others have touched upon it, but teaching, if that's something you're really interested in, you can apply to be associate lecturers at unis, and it's not very difficult. You just need to have a few hours requirements, and particularly with WSU, they always welcome having conjoint lecturers, so have that at the back of your mind. And it's always good to have a record of interesting cases, particularly this year in interviews. They'll ask things like, when were you challenged? When did you have to speak up against a consultant? When did you manage conflicting priorities? So it's always good to kind of keep a record of interesting cases so you don't forget, and also for your own learning as well. Here are some good resources. I will put up or send Dimesh like a Google Drive of good resources, but the things I really like are AMH and MIMS for medications. I really like MD Calc, particularly if you need to calculate things like creatinine clearance. And Thinksalin's actually a really, really good guide. I still get really like nervous around blood sugar management, but it was sort of designed by consultants and registrars to help JMOs manage blood sugar levels, particularly in after hours shifts as well. But I'll make sure I upload all this stuff. But yeah, they're quite useful as well. And you'll find what works for you and what you need as well. And also using the hospital guides. There'll be like guides on warfarin prescribing and guides on like vancomycin dosing, and they're really good ways to like ensure you're doing the right thing. I think also just like a picture I found online, internship, if you don't look after yourself, can make you very physically and mentally fatigued. You do often have conflicting priorities. You have to come in really early. You have like jobs that like you're not unable to do all of them at the same time. Often you don't eat and you don't pee, but just remember to look after yourself, because I think if you look after yourself, you'll be able to provide your best and also feel more optimistic. So I think I sent this to Dimesh, but make sure you prioritize your well-being, and hospitals have a huge focus on JMO well-being these days. So de-stress and debrief, recognize if you are struggling so you can send for help, and this might be talking to your friends, talking to your medical team, or even talking to your DPET. DPET and JMSU are really, really supportive in all hospitals. Activity, I found it really good to have like physical activity, or you can join like hospital sporting teams just to keep your well-being up. B would be believe in yourself. I think it's really easy to feel like a small fish in a big sea and feel like you don't have enough to offer, but remember you do. And without JMOs, like a lot of the stuff that are needed on a day-to-day basis for patients and also for patient safety would not be done. So you're really important, and it's okay if you don't know things, but just trust that you have learned things in your last 5 years. C would be connect with like family and friends. You don't want to let your job take over your life. It's a part of your life. So make sure you're still maintaining all those parts in your pie chart that keep you happy. D would be delve into your hobbies. This is also very useful, I guess, on a side note in interviews as well. They always want well-balanced people, and they want people who do have a life outside of medicine, who have other avenues of happiness as well. So it's very important to find things that make you happy and do that as well. E would be environment at work. Vinay touched upon this. I think if you have a good environment at work, you will be happy. So do as much as you want to contribute to that, whether that's bringing snacks or joining committees or doing advocacy or teaching or just being some fun. I had a registrar who used to like bring a basketball. So if it was a chill day, we'd go out and shoot hoops. Didn't happen all the time, but it was just really fun to come into work. So just try and make it as fun as you can for you and others. And F is food and fluids. Always prioritize eating breakfast, lunch, dinner, look after yourself. And like, it's really easy to go through the whole day without eating, but you can always take aside 10 minutes to just eat in the middle of the day. And G would be give back to those around you. Often you're going to have really busy days and people will help you. And I think it's always nice to give back, particularly if like other people are struggling. So it can post in your intern chat. You can give back to medical students, you can give back to universities, or you can do like charity stuff. So that's always a good way to keep active as well. Yeah, so that's about it. But I'm always open to having a chat, or if you are having a tricky time next year, feel free to call me or message me on Facebook or call me on Facebook. So yeah, there's doors always open here. And I think it's a bit later on, but when interviews come around, really happy to help you guys where I can as well. You guys will be really, really good, and congratulations again.
Thanks so much, Anu. Does anyone have any questions for Anu? Okay, seems like everyone's pretty quiet today. So I'd just like to welcome my next speaker, who's Rohit from Kutra and Neil.
Thanks, Damesh. I just need to be able to share the screen. Give me a second, please. Right. Fantastic. Welcome, everyone. Thank you for coming in today. I understand it's been a long night, and congratulations on finishing this stage of your career. Now, Buongiornos have already spoken a little bit on the financial side of your intern tax returns and what to expect. And it's been great to hear from the other interns as to what your experience will be like. I'm going to talk a bit more about the longer term and just things for you to think about going forward. Now, before we do so, as always, just a quick disclaimer that everything we're talking about tonight, it's general in nature. And if you need any specific advice, we have to look at your specific circumstances. So feel free to reach out and we can discuss after. I've put in a few QR codes in there, and we have a post up on the Facebook page with our details for the Kutra and Neil Wealth Start program. So why can we talk about this? So Kutra and Neil are specialist chartered accountants and have 65 years of service towards medical professionals. I'm part of the specialist medical services team as one of the managers in here, and I work with a lot of our GPs and specialists in assisting them reach their financial goals. Now, what does this mean? What this means is that we know where you will be going forward, and what we find is that the successful doctors have thought about their long-term plans. What we like to say in the office is that failing to plan is planning to fail. Now, from our experience, we know that most of you will go down three paths. Some of you will go down the staff specialist route. Some of you will be going down the GP pathway, and some of you will be going down the specialist private practice route. So what does that actually look? Now, you've actually finished university, you're getting your first job, getting for some of you, maybe most of you, your first salary. And this is generally our experience. Your income's going to be on an upwards trajectory. And thinking about your long-term plans now, will set you up for the future. Use this time to enjoy, learn, and just have fun with it. So our top tips for new doctors are, firstly, as we said, think about your long-term future. So start thinking about laying the foundations for your wealth. I'll talk a little bit about salary packaging and thinking about kickstarting a super and ensuring your income. So if you think you are too young to plan for your retirement, you're at the perfect age, and I'll go through the reason why next. So generally, this example works really good in an actual room where we get a show of hands, but obviously that's not going to happen today in this sort of in these circumstances. So what we find is when we ask people what they would prefer, whether it's $1 million today or a cent doubled every day for 30 days, we find there's usually a 50-50 split in the room. And it's a useful example to think about. And what this really shows is the power of compounding, where if you had chosen the 1 cent doubled every day, in 30 days, you'd have $5.4 million. Now, would love that. Can probably buy a couple of houses in Sydney. The $1 million, maybe you'll be lucky to buy a house in Sydney. But this is an academic example. And the principle behind this is that by starting early, you give your investment more chances to double more often. And on a practical basis, you're getting your first salary. So thinking about something that each one of you will have, that's your superannuation. Now, this is an example where you have 2 registrars. It starts when they're 33 years old and they're both on a $180,000 package. What that means then is you have roughly 10% of your income, so around $18,000 made towards your superannuation contributions. You can put in up to $25,000 a year. So the column in red highlights the difference between someone putting an extra $8,000 a year. And what you find is by the age of 66, the person that has put in the extra $8,000 a year has an extra $463,000. And that's basically what you get for $92 per week. And if I knew that when I first started off, I'd start thinking about this a little bit earlier and making some smarter decisions, maybe not in super, but just in general, thinking about the long-term impact on where my cash is going. Now, I've talked to you about your long-term planning. Let's jump on to the ATO. Now, it's important that you get your relationship right with the ATO now. The first real return that you are lodging now with your intern income sets the tone of your relationship with the ATO. Now, the ATO's got a lot of data about you. They do a lot of data matching and they benchmark. So they know what an intern's expected to make. They know what roughly your deductions are going to be. So it's really good to be on the start the relationship right with the ATO, just like with any other relationship, and maintaining that, because you find that the ATO is a lot more lenient when you do actually need to get some leniency from them. So jumping into your tax return, Bonjournos did this pretty comprehensively, but I'll touch base on a couple of key points. And the first thing is that basically, when you spend money on, maybe you're going to buy a gold-plated stethoscope, you're not going to get that back in your tax. You have to spend money to get that back. And at most, when you spend $1, you will get 47 cents in the dollar. That is due to the tax rates, the table, which Bonjourno showed before. Most of you will be in the 30 cents in the dollar range or so. So that means if you spend $1,000, at most, you'll probably get around $300 back in your tax. Now, feel free to reach out to us. We have, as I said, a post on the Facebook page. And going forward, when you have got your fellowship done and dusted, there is complexity in medical practices. And this is not for you to know. It's just so that you are aware. That's our role, to think about these and keep you appraised and make sure that you're staying on the straight and narrow. You're not pushing the pushing yourself too hard and becoming a target with the ATO. So I've just told you what you can't claim with your what you can claim with your tax deductions. Now we'll jump onto salary packaging. Salary packaging is unique to the hospital system. I wish I had this, but I don't. I don't work in the hospital system. So you really should be taking advantage of this because in effect, it gives you $9,000 a year tax-free, plus the $2,500 in meals. That's roughly $50 a week in going out for your meals. Now, in New South Wales, there is a 50-50 benefit share, which is of the tax benefit that goes to the hospital. But you generally find that irregardless, it's still a saving for you, and it'd be great to take this up. Now, some key basics on salary packaging. So the salary packaging year runs until the 31st of March. And this is interesting because you'll start your internships at the end of Jan. So in effect, the first year is only for 2 months that you have. And your tax year ends on the 30th of June. So there is a little bit of juggling that you have to do with managing the different deadlines. But in the end, just keep in mind going forward after the first year that the salary packaging is a use it or lose it system. If you don't use the $9,000 and meals in the year, you don't get to carry it forward to the next year. So what can you salary package? What you can do is you can salary package your rent, your mortgage, and then what we like to call all the fun stuff that you can't get a tax deduction for. So going on holidays, maybe buying a car, your credit card bills, any of the fun stuff. That's what you can salary package. Now, sorry. So just jumping on from that, what you should watch out for with salary packaging is that it can affect your HELP thresholds if you have a HECS debt. And what you shouldn't package is your deductible expenses, such as your AMA fees and your income protection insurances and the like. So I've just told you what you can claim. Now, where do you spend your money now? And money in the real world is basically based around a risk continuum where your interest rate really shows what the risk associated with that is. And when we Kutcher and Neil, think about debt, we think about debt in two ways. We think about it as good debt and bad debt. And our purpose is to think about that proactively and try and guide you through that throughout your career stage and think about strategies to help you with it. So good debt is tax deductible to you generally, and bad debt is generally the higher interest, the one that you want to get rid of as fast as you can. And there are ways where you can structure things to make it more advantageous for you. So when you're talking about debt, jumping onto your first home, which BOQ did talk about, and the difference when you're looking to buy your first home is that you as medical professionals can, in certain instances, borrow up to 100% of the property purchase, but generally we find that the max is 95%. So on a $600,000 property, your deposit is only $30,000, whereas I, as a non-medical professional, would need to come up with 20% of the property value as a deposit, so $120,000. So the difference in after all the other costs such as stamp duty and legals, you can actually purchase a property for $50,000, whereas I need close to 3 times that amount to actually purchase my first home. Now, we find that a lot of younger doctors will buy a home to manage their cash. Now, what we find is that generally you're going to be moving around a fair bit, and it'll come to a stage where your first home isn't you're going to be a last home. It's not going to be a dream home. You will be upgrading. So we like to think about this in terms of the good debt and the bad debt, and thinking proactively and setting you up for the future in that. So we've come to a situation now where you're fully qualified, you have your home, potentially married, maybe having kids if that's your inclination. What you need to next think about is your biggest asset, and your biggest asset is actually yourself. So you've spent the last 5 years just at university, then gone internship, registrars, and residency. So having a situation where that's at risk is something that we absolutely want to avoid. And we like to think of a concept of at risk and at wealth. We like to think about all the risky items being actually yourself, where there is risk associated with you, and actually putting a barbed wire fence around your assets so that if something does go wrong, your wealth is not wasted. So we would set you up with insurances to protect you and set you up in structures, and that's thinking long term, with our doctors that have thought about the long term plans, about where they want to be in the next 5, 10, 20 years, and setting them up appropriately. So that's sort of a comprehensive overview of what you should be thinking about. Now, we have a Wealth Start program. It's a comprehensive program. It'll be, in the beginning, it'll be about your tax returns and advice on salary packaging and any investments and the like. So the Wealth Start program is actually $299 a year. And what it does give you is a $100 rebate with the AMA. And after your tax deduction, effectively that is $82 a year in terms of your actual cost to you. So feel free to reach out to us. We'll be more than happy to help you out. I think that's it. And did anyone have any questions? That's it.
Yeah, I don't think there's any questions. Thanks so much, Rohit.
No problems. Thank you for having me. Thank you for having me.
That's all good. So moving right along, and there's just 3 speakers left, so hang in there, everyone. So the next speaker that we have is Megan, and she's going to be talking about surviving after hours and some common scenarios that you're going to encounter during internship. Feel free to turn on your cameras. She's told me that she's made this super interactive, and the best way for you to enjoy this and her talk is for you to have your camera on. So make sure you guys do that.
Hey everyone. Okay, so is this working? Hopefully it is. Can you see my screen?
Yep.
Yay. All right, so essentially I can't see the chat. So unless you guys show me your face, I can't see your response to my questions. When I tried this presentation, it ended up being a bit longer than anticipated. So if you like, I can go through it really quickly, or I can get you guys to be involved. Which one do you prefer? I don't mind. Demesh, I can't see the chat, so I don't know if anyone said anything or showed their faces.
Yeah, I don't think everyone's been quite quiet today, so yeah, they haven't really said anything.
Hello.
It's Tim.
Hello. Do you guys prefer me to go through it a little bit more like if this is medicine type teaching more than tips as well? Which one do you prefer?
Generally, we like going in detail, but for tonight, just
Yeah,
because it's been a bit long, and when there's 60 people, it's very difficult for people to actually speak up. So I'd say just go through it quickly.
All right, sounds good. But you guys let me know if there's things that you want me to slow down, just interrupt using your voice. I don't mind. Or show me your face. Okay, cool. So surviving after hours. First of all, congratulations, guys. It's really exciting. This has been a really, really big year. So it's really exciting that you guys are going to become interns soon. So let's get right into it since it's quite late. How to deal with a after hours shift. So I'm going to go in a chronological order, and then in the middle, we'll go through some clinical scenarios. So the first 30 minutes. I think it's really important that you arrive on time, if not a little bit early. So depending on when the handover is, get there on time because everyone will be waiting for you, and it's really stressful if you turn up and everyone's been looking for you. Grab your pager so you don't forget it. and then sign on. I don't know if there's a sign on sheet in other hospitals, but we have one. And then you get the phone numbers of the people who are working with you, especially the registrar, because that way you can easily contact them when you need to. And then after that, everyone groups together, they receive handovers in a big group where the people from the previous shift, and we look on EMR to see handovers that teams have put up, so specific sick patients that they think should be flagged. And then you can split up, and usually you get a mini handover from the previous shift. So if you're starting night shifts, the night intern gets mini handovers from all the day interns about like particularly sick patients or little jobs to chase that weren't important enough to be discussed on the big screen. And then next is to prioritize your jobs. So that's pretty important. This is literally what the PAL census task list looked like yesterday. So this is a pretty good list. Like this is a nice shorter list compared to usual, but this is essentially what you'll be faced with at the beginning of your after hours shift. Then in addition, you have to respond to pages as well as like jobs that just come to you when you're on the ward. The nurse is like, hey, are you the after hours doctor? Can you do this? So this is a whole mix of things that you need to do, and it looks quite overwhelming. So I have created a piece of paper. I haven't actually shared this with anyone yet, but this is my creation. Also, disclaimer, all of these things are like from my brain rather than from ETG. So take the like medical tips with a hint of salt. It's about approach rather than actual therapeutic guidelines. So different people have different ways of prioritizing their jobs. I put mine in 6 sections. So I get a piece of paper. Can you guys see me as well? Yes, okay, cool. I get a piece of paper and I fold it up, but essentially it makes into a little booklet that I can tuck into like the front part of my scrubs. And I have in-person jobs and then computer jobs. And then the other side, I have clinical review / rapid responses. I put my pager number up there. I write which wards that I cover. And then over here, I put like the number of the registrar, like the phone number, and then handover. So at the beginning of handover, I write down the sick patients that I need to cover over here. And on the inside, I put patients that I want to discuss because I need to, you see lots and lots of people and I want to collate them so I can talk to the registrar. And then up here is pending pages. So sometimes you get paged when you're in the middle of doing other things and you don't have time to respond. So I write it down so that I can respond afterwards. Some people organize it by ward. Like I think Prince of Wales, you cover quite a few wards. So there's not much space to write it in, like to organize it in a nice way. So I like organizing like this. Some people have a book that they bring around, they write chronological jobs in. But essentially, I think it's really important that you find the best way of prioritizing how you do your jobs because it takes a big weight out of your brain. So this is a fake census health task list that I've made for all of us that we can go through. So I'll show you an approach in terms of prioritization. And this was meant to be the interactive bit, but I will do the answering. So, but if you want to, you can jump in. So in terms of jobs, so for example, how do I use my thing? All right, bed 1, ward 6, bed 17. So this is how the actual census task list looks like. It's like the location and the bed of the patient. Usually the patient details are at the very front, but I've kept them out for this exercise. There's headings. So these are all like specific headings that can be ordered on EMR with a time frame in which it's meant to happen. So more than 2 hours, 1 to 2 hours, less than 1 hour. The person who requested it, the phone number, the ward, and then what the job is. So this is how I would split it up in my own piece of paper. But essentially, if someone needs an IV cannula, I have to go in person and do it. So that's going to be an in-person job. At the same time, I have a look on the computer and see why they need the antibiotic. If they need an antibiotic that's due at a certain time, that way I know which time I need to do it before. And so I write down 8 p.m. over there. Sometimes you can have a look at the notes and they actually don't need a cannula. The nurses were just asking for it because they had one before. And you can just be like, no need for a cannula, patient to be discharged tomorrow. You don't need to do the job at all. Ward 9 renal, please collect repeat trop. So that's definitely really important. Pop that in an in-person job to do at 7 p.m. Patient has fever to 38.1 degrees, please review. It's probably important to have a look and probably clinically assess a patient who's febrile. So that's an in-person job as well. Ooh. Okay, the next one is renal, please trace evening EUCs and replace as appropriate, patient is hyponatremia. So essentially, this means that in patients with hyponatremia, as you know, you've got to correct the levels of sodium quite gently. Otherwise, there's a risk of like pontine demyelination and that sort of stuff. So someone's done the bloods at say 3 p.m. and they want you to get and the results haven't returned by the time they come home. They finished their shift. So it's your job to check it. I've put it as a computer job because if it's correcting at the correct rate, I don't need to physically go see the patient and do anything. I can just say, evening sodium chase going, like tracking well. Don't need to see the patient. What else? Is this helpful? Is this too detailed? Like, tell me if I'm going too slow, okay? What's next? Patient for discharge today, please provide discharge and script. You need to go in person. So that's in the in-person job, but be aware, sometimes the jobs trick you up. So on after hours, you should not do discharges. That's not your job. It will take you like half an hour to do a good discharge, especially the patient's been here for a long time and you don't know the patient at all, and it's not your job to do after hours. So don't get tricked. What about this? Patient meal by mouth for OT tomorrow, withhold insulin. At Prince of Wales, so it will differ for different hospitals, but at Prince of Wales, everything is charted on computers except for fluids. So this can be a computer job for me to rechart the insulin. Review chest x-ray. So sometimes it's important to find out why you're asked to do certain jobs. When they say, please review chest x-ray, I'm wondering why. Is it as part of a follow-up for a septic screen? Is it as part of figuring out why a patient has new, like, you know, are you worried about something in terms of cardiothoracic? Sometimes it's because it's like they've taken out a catheter and they just want to make sure there's no pneumothorax. So looking at the rest of the order of the task list, like what ward it's from, gives you a better idea. So that's a computer job as well. You can just document chest x-ray looks clear, no pneumothorax seen. Patient complaining of rash. So this is a tricky one. Sometimes you'll need to call or have a look in the notes to see whether or not a patient's rash is actually serious. Sometimes it can be just a long-standing known rash and you can just give some supportive care, like, you know, sorbolene cream or whatever. But other times, if you look at the notes and they look like immunosuppressed, then you should definitely review them. But in this case, they're an old person. I don't know what's happening with them. I've got to go in person. Fever to 37.6. Normally you'd be like, is that a borderline kind of fever? But then you look at the note again, they're on the oncology ward. So you'll be afraid about febrile neutropenia. So that one's definitely on the to see list, like in person as a priority. Other jobs, like patients state they take Panadol, osteo, not Panadol at home, please rechart. Like that's really legitimate jobs that you have to do. I just put it on the computer list. Sometimes you don't get to it, sometimes you do, and that's okay. Patient complaining of pain, please chart more endone. Once again, I guess it depends on, you got to have a level of suspicion as to why they have the pain and why they need more medication. Ankita talked about that analgesia stuff already, so I won't go into much detail. But if you have a look, like, so I would look into the notes. It's a young man who's fractured his radius. He's not been charted anything. So except for one stat dose of endone, so it's fine. I can just chart it on the computer. Some Panadol, some endone. And please order APTT, patient is on heparin infusion. So sometimes you get asked to order things just because the nurses can't. So you can just do it on the computer. And patient for angio tomorrow, please chart prehydration fluids. That's in person for POW, but in some other hospitals, you can chart it on the computer. Ward 6 Jerry's, please chart warfarin. That's a computer job because it's a med that I can just do remotely. Just check the INR, make sure it's okay, see what they've done in the past, chart your warfarin. And Ward 6 Jerry's, patient requesting sleeping tablet. I guess that can be done remotely. In an ideal world, you'd go and see the patient and see why they're requesting and what kind of tablet they're talking about. But often you get really caught up, and so it's a computer job. Finally, admit less than 1 hour, patient family wanting to talk to doctor. So having a look, it's the oncology ward, and I don't know if it's going to be a Breaking Bad news kind of situation, but regardless, that's not usually a job that you should do on after hours. It's not your job to do discharge summary. It's not your job to provide updates to family members on patients that you don't care for. So I would actually just take it off the list. I wouldn't do it. You can click not appropriate at this time, and you can document like ask to see patient family, but not appropriate at this time, dating to please review. Or you don't even have to document it all because it's not something that you should do on after hours. Okay, so essentially the really big one from, oh no, that really big list has become much, much smaller. This is that piece of paper that you'll be carrying around with you. And this is an example of like a real piece of paper that I had from my last shift. So these are my jobs in person and in computer, things to review, that sort of thing. Okay, notice that I put some stars. There are some things that are important that you need to be aware of. So I put a star at the CHOP because at 7 o'clock, I need to get that CHOP done. And I would set an alarm at 6:45 to make sure that I do it. I also want to put a star on the febrile patient in the oncology ward because I'm really, really worried about febrile neutropenia. Cool. So general tips, unless it's an urgent question, like a clinical review that you're worried about the patient deteriorating, you can pop your questions together, and that's that way you call your reg to discuss a few patients at a time. And that's why I have this section, the to discuss section on my piece of paper. So I write down just a number so that when the reg calls me or I call the reg, you can be like, hey, these are my few questions. If you're worried about protocol, so there's lots of protocols for warfarin charting, heparin charting. They've all gone out of my head now, but there's lots and lots of protocols. Sometimes that can help guide your medical decisions. You can have a look on the intranet, or you can ask any of the nurses because often they use those protocols to guide the medications they give out. Set alarms for important time-dependent jobs. Bring spare materials with you. Sometimes wards don't have stuff, like the rehab ward will almost always never have any blood collecting things. So if you bring that yourself, you save so much time. Pack some snacks, pack some water. Ideally, like you have time to eat, but sometimes that doesn't happen. And so you have to make sure you feed yourself. And if you get paged, ask them to put it on the census task list as well, in case you don't get to it. And that way it's not a job that's missed. Because from the point of someone who's, say a nurse is concerned about a patient, they page you and you say, okay, I'll go see it. But then you get a code blue and you have to go immediately to that. You forget that job, that the nurse thinks that she's done her, like he or she has done their job. But actually it's been lost in translation. So making sure that there's a safety net. Thanks for nodding, Dimesh. It's very helpful. Okay, so we'll do some quick clinical scenarios. The general approach that I'd like to do, so in after hours, your job isn't to diagnose everything and treat everything. Your job is to help keep patients stable, essentially keep them alive. And you have a very limited amount of time. So how can you utilize the time most effectively? Before you see the patient, when you get called, when you get paged, when you see a job, you can call the phone number. And what questions can you ask the nurses about the patient? And what jobs can you get them to help you with before you even turn up? Then you look on the computer. What can you be looking at? Their medications, their background, why they came in, all these things that help inform your clinical ideas. On the ward, assessment. So that's your history and exam. What you can do at the bedside. So right there, can you put in a cannula? Can you take bloods? What can you do right next to them? And then the plan. What further investigations do you want? Do you want an X-ray? Do you want antibiotics? An X-ray or CTPA, anything. Treatment. So what kind of initial treatment you're going to put in? And safety net. So please notify a medical officer if blah, blah, blah. And I've put in capitals discuss because especially at the beginning of your internship, you definitely need to discuss it with a registrar. And finally, follow up. So the job doesn't finish when you finish documenting for the patient. How will you make sure that the things that you've ordered and the things that you're trying to find out about are appropriately chased? Because you finish your shift and then the results might not have come back by then. So fever. On the phone, you want to ask, this would have been so fun if you guys were in person and I could quiz you guys, because I know that I would have learned a lot. But it's okay, it's really late. On the phone, you get the patient details. You want to find out what other vitals they are. You want to see if the nurses are concerned. And then you ask, can anybody take bloods? Because when a patient after hours has got a fever, you're worried, almost always in after hours, you do a septic screen. And so if you can ask the nurses if they can take bloods, then you can be like, okay, can you please take some blood? And I'm going to order remotely an FBC, EUC, LFT, VBG, blood cultures. And can you do that before I even turn up? That way, with any luck, maybe the VBGs come back when you arrive on the ward. What else? Look at the notes. So why did they come in? Was it surgery? There's a different pathway that you go down. If they're surgical and they've got, post-operative fever, is a different thing from a 90-year-old man who's come in with renal failure and he's got a fever. what's their background? Are you worried about like their fevers? So immunosuppression, malignancy, have a look at their investigations. Is there a bug that's turned up on a previous septic screen from this admission, and what sensitivities they're on, what sensitivities they have, what antibiotic are they on, and is it sensitive to that? Are they on any, they're surgical, are they on anticoagulation, that sort of thing. Bedside, you got to do bloods, you got to do a cannula, because you might want to give them antibiotics as well through the drip, as well as you might want to do fluid resus if you're worried about septic shock. Assessment, so see if there's anywhere the infection could come from, or like the 5 Ws, like wind, water, walking, those things. And then further things, you might want to do a complete septic screen, and then like, you know, do you want to sort them for COVID, not COVID, etc. Do you want to do more things? If it's an immunosuppressed patient who's, you know, got a fever, to what extent do you go maybe an LP? Panadol can sometimes, Panadol help with the fevers. Antibiotics, IV fluids if you're worried about their if they're worried about them being septic, if say the lactate from the VBG comes back high. And then how you safety net is notified that there's further fevers, hypotension. If you're worried about a PE, then, you know, tachycardia, that sort of thing, tachypnea. And then census task list, you add a job for the next person or for yourself if you're on for the whole day, chase the septic screen. I'm going to go through the next ones a bit faster, just to like speed up. Hypertension, essentially what you really want to ask the nurses is, can you repeat a manual BP just to make sure it's not a machine error? And what medication are they usually on? Because can you just give something that they're due for like early? Say you get called at 4 o'clock, they've got amlodipine due at 5, just say give the 5 o'clock one early. And that often can sort it out really quick. You can also check, essentially when you're calling on the phone, you want to find out details about the patient and how worried are you? What jobs can you give them? So are they symptomatic? That's bad if they are. Have a look at if you can give anything that they already have. Look for red flags. Are they pregnant? That sort of thing. Do you want to put a cannula in if they've got hypertensive urgency or emergency, so you can give stat doses of medications that can lower blood pressure quite quickly? Are you worried about, you know, preeclampsia? Do you need to do a PCR? Get them to repeat the blood pressure. Treat them if they're in pain and that's why they've got hypertension. Otherwise, sometimes people, I would discuss with the registrar before giving anyone a stat dose of any antihypertensive. I wouldn't start one by myself, but sometimes some of my friends who are in term 4 and relief already do. And then safety net. Hypotension, the questions that I like to ask are what's causing that hypertension. So making sure that it's not because they're becoming septic, making sure that checking if they're symptomatic, so like end organ damage type things. Can they repeat the blood pressure? And if they've got IV access, can I do a phone order for fluids? You can just say, like, instead of like physically going to write the order of fluid, you can repeat the order twice to 2 different nurses and they can do it without you going there. So that's a great tip. And then if they've got no fluid restrictions and that sort of thing, you can phone order a stat bolus of 250 mils just to try and see if that will support their blood pressure. Otherwise, you know, are you worried if they're post-op? Are they hemorrhaging? That sort of thing. What else? Yeah, you want to monitor. So the plan, you want to monitor their urine output because end organ damage type things. You want to see if you want the nurses to be aware and flag if they start getting fevers or have reduced GCS. So if you write down certain things that you're worried about, then the nurses have a better idea of when to escalate rather than just leaving it for whichever, like it by itself. A patient who has a fever of 35.6 of 37.6 might not be elevated, might not be escalated, but if they already had hypotension and then they get the fever, you would want that to be escalated. What else? Fall, you want to ask if it's witness or unwitnessed, if there was head strike, get into postural blood pressures, check if there's any obvious injuries. I'll send these slides through. But you want to essentially, the most concerning fall is an unwitnessed fall in anyone elderly or on anticoagulation, or even a witness fall in anyone elderly on anticoagulation with head strike. So the 2 things that you want to do when someone falls is 1, find out why they've fallen, and then 2, find out if there's any consequences. In older people who have an unwitnessed fall, sometimes in addition to the postural blood pressures, I do bloods, including CMP, to check if there's any electrolyte disturbances that are causing their fall, causing them to be unsteady. Non-pharmacological interventions can include a falls alarm, asking them to do special nursing, so one-to-one specials and that sort of thing. Pharmacological things could be just like analgesia if they've got pain. But, you know, the question is, do they need a CT brain? Sorry, this is all really rushed. I'm trying to make sure you guys get through it. Hypoglycemia. This is a really good one. Sometimes you get paged because the patient's blood glucose is 2.8 and normal is above 4. Essentially, you can just say over the phone, please give them some glucodine, please give them some apple juice, please give them some food. Recheck the blood sugars in 30 minutes. And it's usually okay. But you should check if they are type 1 diabetic. And then the plan, I guess, is acutely how to manage the acute episode of hypoglycemia. And then in the future, how to prevent further hypoglycemia. Do they need their insulin dose reduced? Do they need those sorts of things? But often you can say that you can write in your plan, day team to please review insulin doses given episode of hypoglycemia. Cool. Chest pain. Oh, this is so important. So over the phone, you can ask like the cardinal features of pain and find out which chest pains are risky, and always get them to do an ECG. In the background, you can look for higher risk factors that point towards cardiac disease or, you know, pulmonary causes of that chest pain. I always discuss chest pain. Some things like hypoglycemia, I don't discuss in my reg. Sometimes if patients like mildly hypertensive, I don't either. But chest pain, I always do. And I get them to do a repeat ECG for dynamic changes. And on the census task list, you make sure you get them to chase a chop. So bonus, in a code blue. Sometimes you can be the first one there. I've been to the first one there before and it was quite terrifying, but people turn up like really quickly. If your brain freezes, you go back to the basics of doctors A, B, C, D, E, F, G. And then, but usually when you do turn up as an intern, you're not going to be the team leader. And so what jobs can you do? You can try and get IV access, you can order bloods, you can find a computer, start documenting the code blue, start reading what their medical history was. You can give some guidance to the BPT when they turn up. You can also support the families. Sometimes like the last code blue I went to, I was the last one to turn up, and this guy's wife was just wailing. And I took her out from the bedside and I just explained to her what was happening. And while that's not like innately medical in itself, it facilitated the rest of the team being able to perform the code blue. Oh yeah, this is a fun one, extra, sleeping tablet. Essentially, sometimes I like to leave the patient requesting sleeping tablet job for the last, because sometimes I get there and they're already asleep. So I just document patient to sleep, no requirement for sleeping tablet. But other times they like, I like to offer melatonin rather than Temaz. But lots of people like specifically asking for Temazepam, but it's a big benzo risk, especially in older people. In the last 30 minutes, you want to see what jobs are the most important and then prioritize them. You're not going to be able to do everything, and that's okay. So prioritizing things is the most important thing. Just seeing, who are the sickest patients that really need to be seen immediately. Sometimes even clinical reviews can wait. You can even just eyeball them and be like, I think they look okay, and hand it over to the night intern. Finish your documentation just so that the plans that are in your head get carried out, and leave your pager behind, because I always go home, I always get halfway to my car and then I realize that the page is still on me, and it's really sad to walk back. What else? So now hopefully after this talk, this big list looks a whole lot more achievable to you. Bonus night shift tips. Day before, you let everyone who's in the house and people who around you, like upstairs neighbors or whatever, know that you're going to be on nights, because it's going to be really, really horrible if you got woken up by them moving furniture. Make sure you find out how to get the best transport for yourself and parking. I discovered too late that the place I moved out to, the bus only came every half an hour after 8 p.m, which was just really painful to discover the first time. I had to take an Uber home, it was bad. Cost me money, and I didn't want that. I prepare food and snacks. I like to wake up early, wake up normal early time the day before I start my nights, and then do a full day. That way I get really, really tired. Other people like sleeping in and doing a short day and then going to sleep at a normal time and trying to sleep as much as they can. After the shift, make sure to reduce the amount of sunlight you get exposed to, because that will affect your circadian rhythm. And some people use medications to help them go to sleep. So melatonin, temazepam, Restovit, which is doxylamine, antihistamine. Those are some things that people use. I haven't tried any of them. I just have like eye masks and like nice housemates. But like a lot of people use little medications. And then when your nights finish, it just depends on different people. You can try what you need. When the whole set of nights finish, I sleep for 2 or 3 hours and I struggle awake. And then I try and sleep at like 8, 9 p.m. Other people like go for a swim, go full out for a full day, don't let themselves stop, and then they sleep a normal time. Final tips, it's really, really important that on night shifts or on after hours at any time, you take care of yourself. Because if you need to pee and you don't pee, when you review a patient, you're not going to be thinking about the patient. You're going to be thinking about your bladder. And you're going to be thinking about hungry or whatever it is. You've got to take care of yourself even if you don't feel it. Prioritization is probably the most important thing in after hours. Remembering that it's not your job to fix everything for the patient. It's to keep them stable until the normal team comes over. And finally, it's always okay to ask for help. So at the very beginning of my internship for after hours, I would literally ask the reg, is it okay if I give Panadol? I've checked the LFTs, I've checked this, I've checked that. Please, how much Panadol should I give? And now it's like Panadol for everybody. So it's okay to ask for help until you're like, and it's better to be safe than to be sorry. Cool. Any questions? Sorry it took so long. No?
Everyone seems really quiet today.
That's all right.
Thanks so much, Megan. That was so comprehensive, and I'm sure everyone learned at least a couple of things from
We'll
that.
send some slides around.
Yeah, thanks for that as well. So moving on to the next speaker tonight, we've got Grimsey Wealth talking to you guys.
Thanks, Dharmesh. Hopefully everybody can hear me and see me. And I might try and share my screen as well. Just a second here. Here we go. Can you see the presentation, Dharmesh? Yep, cool. Let me just, and still see it? Good. Great. Okay, thanks everyone. I know it's getting late, so I'll try to keep this pretty short. Also conscious that Rohit presented recently and there's a bit of overlapping content here, so I'll try to skip through anything, but it's always good to hear it twice. It might sink in a little bit better. So today, I'm just going to quickly talk about Grimsey, quite similar to Kutcher's and Bongiorno's, who you would have also seen present earlier today, in that we're, I guess, a multi-service financial services firm that specializes in medical professionals, so on the accounting and the wealth creation side and finance. So we've got offices in Sydney and in Melbourne. Today here, just to give you a few tips. Yes, for your intern year, similar to what you would have heard previously. So as I said, I'll skip over some of the ones you would have already heard and focus on some that you haven't. So first of all, salary packaging, Rohit, I think, covered that really comprehensively. So that was some good information there. I think in summary, in terms of salary packaging, the main things are, don't package something that you can claim as a tax deduction. That's a really good tip. And then just in terms of the timing of the packaging, there is that period in your first year, I guess, from April to June, with the fringe benefits tax year different to your normal tax year. I guess the simple strategy there, without going into everybody's details personally, is to package as much as you can until the end of March, and then pull back on the packaging between April and June, and then start packaging again after June again. And then moving forward into your second and third years, it won't make a huge difference around the timing. It's just when you're starting, because you only have a partial year of income in that first financial year, ending 30 June next year. That's why there is that sort of timing issue. But that's probably the main thing around the packaging. I'm not sure if it came up in Rohit's presentation, but just understanding how packaging will impact your adjustable taxable income. And essentially that's your income that the ATO looks at for determining if you have to pay the Medicare levy surcharge if you don't have private health cover. So basically when you package something, essentially twice the amount of what you're packaging gets added to your income for assessment purposes of Medicare levy surcharge. So if you're earning 70 grand and then you package say 10 grand, you're going to have 20 added to it. So you're at 90 grand now and you're hitting that Medicare levy surcharge. So just be aware of that if you don't have adequate private hospital cover or health insurance, that there might be implications there. And probably the one that most people get caught out on is the help debt or HECS debt. So again, the salary packaging, it gets grossed up. So roughly 2 times the amount you've packaged gets added to your assessable income, and it's going to push you into a higher bracket for help debt. So it means you're going to have to pay more help debt than you probably expected. And it's going to impact when you do your tax return. You may not get as big a refund as you're expecting, or you might have to pay some money when you do your tax return. So obviously help debt is debt. You have to pay it at some point, but you're just paying it down faster. So just be aware of it, not to get caught out. There's not really any way you can avoid it, but just something to be aware of in case you're sort of waiting for that tax return to come through and spend it on something else. Typical tax deductions for medical professionals. You probably saw some of these earlier. Home office is a big one at the moment because of COVID. The government's incentivizing, I guess, it appears to be, had some generous stimulus around the home office deduction, increasing the hourly rate or the hourly rate that you can claim from 52 cents to 80 cents per hour. But there is caveats there. If you do take up that option, you can't claim things like your home internet use, if you've bought some home office, furniture or technology, other things like that. So just be mindful of the impacts of claiming the 80 cents over the 52. So that's where a tax agent like ourselves or the other presenters today can help out with that. Any additional, next year if you start, you've got to buy your own PPE out of your own pocket. You can obviously claim that as a tax deduction. Professional associations, AMA, ASMOF, those sorts of things, you'll be able to claim as a tax deduction. Self-education expenses, textbooks, things like that. Phone and internet is a really common one. You can claim a percentage of your mobile phone and home internet costs. So you sort of just estimate reasonably what percentage you're using your phone and internet for work-related tasks. So that can often be quite a good claim. Conferences, if you're traveling to anything that's work-related and you're paying for it, you can claim the travel costs. And if you're staying overnight, you can claim meal costs as well. And then again, think about the timing of the tax deductions in your first year. If you've got to incur any expenses towards the end of the financial year, you're better off incurring those after 30 June, pushing them into next financial year, because you'll be in a higher tax bracket next financial year. So you'll get better bang for your buck on those expenses. So if you're thinking about buying any sort of higher value expenses, push them back if you can. Tip 4, start your wealth strategy with the end in mind. So hopefully once you start having an income, you'll start thinking about savings and then what you're going to do with those. So I guess the main thing here is, have a goal, whether that be buy your first home. Rohit mentioned before around, what sort of deposit you'll be requiring, maybe 5% or potentially 0% with some of the banks. So the stamp duty considerations there as well, depending on the value, but working out what are your financial goals, whether that be in 2 years, 5 years, 10 years, and then looking at your income and your spending and then sort of creating a plan to get there. Another thing to consider is it ties into what you're actually investing in. Lots of people are getting into trading now since COVID. People are buying ETFs and shares, buying Afterpay stocks, all the Australian tech stocks. So just be mindful that, generally equities are medium to longer term investments. Markets can go up and down. They're quite volatile. If you need that money in the shorter term, you may reconsider, or at least don't put all your savings into shares, because if you were invested before COVID, you would have seen how quickly and sharply the market can drop. And if you needed that money in say April, you probably would have lost about 30% of your savings, whereas you could actually ride it out. And at the moment, you're probably back to where you started if you're in Australian shares. But other financial crises that we've seen haven't had the quick recovery that COVID did. The GFC took 3 to 4 years to recover. So if you invested that money, you might have been waiting 3 or 4 years to get it back. But in the long run, shares generally outperform any other asset class. So you just got to think of the timing of your goals and what you're putting the money into. Bucketing helps if anyone's a reader of the Barefoot Investor, big advocate for sort of creating those bucket accounts. So it is a good idea. There are also apps out there that you can use, and new digital banks coming to market. If anyone's sort of into the latest technology, there's a bank called Doe. There's a bank called Zinja, I think it is, Ninja with an X. Not quite sure how to pronounce it. My Prosperity is another tool. So they've got cool apps to help with savings plans, working out what you're spending, and helping with your goals. Protect your biggest asset. This is one we really encourage with all of our medical professionals. Insurance. At the moment, your biggest insurance policy is probably on your car, which might be worth 10 or 20 grand. Your biggest asset is your future income. So you really need to look at, well, what if something were to happen to you and you weren't able to work potentially for the rest of your life, what's the loss of income over that period? 40 years of income is easily your biggest asset. So you need to protect that. So I would strongly recommend, once you've started working, it's hard. You need to have an income before you can get income protection insurance, but to speak to an advisor about that. There are going to be some changes to the industry towards the end of next year where the policies won't be as good as what they are now. So strongly recommend, once you start working, looking at that income protection. Understanding your finance options. You would have heard about this from Rohit. BOQS would have mentioned it. So yes, it's great. Medical professionals, you get access to some really cool lending packages that no one else really gets access to. So the main thing there is making sure you're speaking to the right people about that, the Kutchers, the Grimseys, Bongiornos, even BOQS. We have access to those packages. If you go to your normal mortgage broker, they're not going to have the relationships with the healthcare arms within the banks to do that. And even walking into a branch with the banks, you're generally not going to get access to those packages. So you need to sort of go through those channels to get access to those specific packages. It's definitely still able to borrow 95% with banks at the moment if you're looking to live in the house. 100% loans are available still, but just be mindful of the way they structure those loans. They can be accelerated payments in the first few years. So you just need to make sure you can actually afford it when you're doing that. Yeah, so those options are there. And Rohit has a really good slide earlier just around the longer term strategy with buying. Your first property is probably not going to be your last property, and it will become an investment property. So it's really good to seek advice from businesses such as ours and the Kutchers and the Bongiornos around planning for that, because there's ways you can structure that loan that are going to have long-term, tax benefits by doing it right from the get-go. And that sort of flows into tip 7. So starting a relationship with a specialist practice. So the presenters you've seen tonight are probably the main ones in Sydney. So it's good. You've had exposure to all of them. We all do very similar things as a focus on medical professionals, but I guess the real benefit for all of us is that we offer all financial services. So kind of your one-stop shop. You don't need to have a separate mortgage broker, a separate financial advisor for your super or your share portfolio, a separate accountant. You can get that holistic service from us. So always worth, meeting with them, just seeing who you connect with, who you work well with, and taking it from there. And it's never too early to start. Don't think that you need to have, $1 million in net wealth to talk to a financial advisor. And we are also offering a package exclusive for graduates this year. Quite similar to the other ones, where we'll do your tax return, either the one that's just passed or next year's if you've already done it or didn't have any income, you're not working and don't have a tax return for last year, but also include just an annual review meeting for a health check, and then general advice on various things along the way throughout the year. So it's 12-month engagement, and we can answer sort of any of those financial related questions along the way, and we can help you out in terms of insurance advice and finance advice, if that's something that you're also looking at. So yeah, if you want to book a complimentary consultation with myself, that can be via face-to-face in our office in Pyrmont, or we are doing Zoom and Teams and Cisco meetings. You can scan that code there, and you can actually book directly into my diary from that code. Otherwise, we will be sending out an email to everybody with the details to book that appointment too. And that's it for me. Any questions for myself? Checking the chat.
Yep, I don't think there are any questions.
Okay, back to you.
Thanks so much, Alex. And just a quick note on questions as well. If you have any questions for any of the sponsors, for the speakers, feel free to get in touch with them. I'm sure they're very happy to give you a response and give you the answers that you need. So with that said, we move on to the final speaker for tonight. We've got Dr. Annabelle Rafferty from AMA, who's going to be talking about interns' pay and working conditions and how the AMA can assist you guys with that.
Hi everyone, I'm Annabelle and I'm at the AMA. I'm just trying to share my screen, but I can't at the moment. So if there's another presenter that's sharing their screen, I'm just getting an error that I can't share while someone else is. So please bear with us for a moment.
Yep, just give me 1 second. I'm just trying to contact Alex.
No worries. There we go. Let me try now. There we go. Can you guys all see my screen now?
Yep.
Wonderful. All right, I'll get started. So as I said, I'm Annabelle and I'm from the AMA New South Wales. I'm in the workplace relations team. I'm one of the advisors there. And I'm going to be talking to you about membership with the AMA, as well as your award and some of the main conditions of your employment as you head into your internship next year. So we are running an intern offer at the moment. If you join the AMA New South Wales, you'll get a Littmann Classic 3 stethoscope. There's a $19 joining fee, and intern membership for next year will be $28.50 per month, but you will not pay for membership until March next year. So you'll get a free period and a stethoscope, which is a great deal. And the stethoscope is something that can stay with you for your whole career. So we've got a few marketing videos from a few key AMA people floating around. So if you've got some time, try and find those because they're a good watch. I really enjoy them. So some of the main membership benefits with AMA are our workplace relations team. We can provide you with workplace advice and support on collective and individual matters. We have a number of events and networking opportunities throughout the year that you're welcome to attend, albeit COVID-19 has made that a bit different this year, but we have still been doing events and different ways for doctors to engage with us. We have a number of different avenues for advocacy, and as a doctor in training, you can join our Doctors in Training Committee, which I'll speak about a little bit later, but it gives you the opportunity to really get involved in advocacy and some leadership opportunities as well. We have a number of commercial benefits and partners with, financial services firms, as well as other corporate deals where you can get discounts on RM Williams boots, for example, which is a popular one for junior doctors. So yeah, if you're interested about those sorts of benefits, take a look at our website because there's a bit more information there. So as I mentioned, as a member, you'll receive access to our workplace relations team of advisors, and we've recently helped members get paid for mandatory training, get access to maternity leave, seek reviews on training decisions made by the college. You can also contact the team to get help to ensure that your study leave entitlements are paid, although you don't get study leave as an intern, but I'll talk to more about that later. You can also, get issues resolved with AHPRA, as well as medico-legal issues relating to complaints if they do arise. So we're really here to help you with all of your workplace matters, whether medico-legal or, workplace investigations or anything like that. We have a series of one-shot coffee talk emails and associated guides that you should be getting to your inbox next year. The guides sort of answer frequently asked questions on a number of topics such as unrostered overtime, as well as remuneration, leave, all those sorts of things. So if you're already a student member, I'd encourage you to have a look at the website or keep an eye out for these next year because there are heaps of really good information in there that you can sort of have a look over and understand before you start your internship. So there are a number of instruments that underpin your employment in the public health system, and they are your award. So you have the Public Hospital Medical Officers State Award, and that's your award. You'll have your letter of appointment and contract, which you'll receive individually. And then there are also New South Wales health policies and policies that apply at an LHD level. So they're all interacting and they all outline certain conditions of your employment. So hours of work, full-time employees will be rostered to work 40 hours per week, but you will only be paid to work 38 hours per week. So the additional 2 hours will accrue monthly and they'll go towards your allocated day off or your ADO. So in any consecutive 7-day period, you can be rostered for 40 hours and in any 14-day consecutive period, you can be rostered to work 80 hours. As I mentioned before, the 2 extra hours that you work each week accrue to your ADO each month. So ADOs should be rostered and taken monthly, and you can't take half ADOs. So any ADO that you do accrue for whatever reason will be paid out when you leave New South Wales Health or if you change to a different district. Rosters. So your roster should be released to you with a minimum of 2 weeks notice. In an emergency, your employer can change your roster. Generally, shifts can be rostered for a minimum of 4 hours and a maximum of 14 hours. And there should always be a 10-hour break between rostered shifts. Meal breaks. So whether there's a paid or an unpaid meal break will depend on the shift that you're working. So day shifts during Monday to Friday, you'll be entitled to a 30-minute unpaid meal break. If you're not able to take that meal break for whatever reason, you should speak to your JMO unit about the most appropriate way to claim that time. If you have no luck there, you can always contact us, or if you're not sure, you can contact the workplace relations team for some advice as well. And meal breaks during evening shifts, night shifts, and all weekend shifts are paid there. So those meal breaks will be paid. Overtime. So you'll be required to work reasonable overtime, and that overtime can either be rostered or unrostered, and I'll speak about unrostered overtime next. So generally time worked in excess of 10 consecutive hours will be paid at overtime rates, and time worked in excess of 80 hours per fortnight will also be paid at overtime rates. So when you're getting paid overtime, the first 2 hours of overtime will be paid at time and a half, and the additional hours thereafter will be paid at double time. In addition to this, any time worked on a Sunday will also be paid at double time. So unrostered overtime, I'll talk about that. Unrostered overtime, it's exactly that. It's overtime that you've worked that doesn't necessarily appear in your roster. So there are certain circumstances where you will not need prior approval to working unrostered overtime. And those circumstances include medical emergencies, when you have to transfer a patient, extended shifts in theatre, patient admission and discharge, completing outstanding patient transfer and discharge summaries, late ward rounds, mandatory training, clinical handovers, and hospital-based outpatient clinics. So if your unrostered overtime that you're working doesn't fall into one of those categories, then you will need prior approval to working it. On our website, we have a video that you can watch on how to claim unrostered overtime, as there is a new online claiming system. So that's on the DIT page of our website. So if you have a moment, it's a really useful video. We've got some good feedback about it. So if you have the time, I'd encourage you to have a look at that video, before you first claim your unrostered overtime. So in regard to leave, you will be entitled to 4 weeks of annual leave per calendar year, and you may accrue additional annual leave in some circumstances. So for example, you'll accrue additional leave if you're working on a public holiday, or if a public holiday falls on a rostered day off, you'll accrue an additional day. In your intern year, your annual leave is generally taken in one consecutive period, and it's generally in the relief term of your internship. Sick leave, so full-time employees will be entitled to 76 hours of paid sick leave, or 2 weeks. Part-time employees will be will have the same entitlement, but on a pro rata basis. Now, there is a clause in the award that states that you become eligible for a full year's worth of sick leave on the first day of the 4th month of your employment. So that's after 3 months, essentially. However, because of COVID, there have been some changes in this space for this year. I'm not sure whether the ministry will be extending that for next year. But if you have any questions about this, there are usually FAQs in your LHD or sort of policy documents that are LHD specific that usually dictate what's going on. Again, if you have any questions, that's the sort of thing you can pick up the phone and call us about, and we'd be more than happy to have a chat with you about it. So maternity leave, full-time and permanent part-time employees will be entitled to 14 weeks paid maternity leave after 40 weeks completed continuous service. As I alluded to before, in regards to study leave, you won't be entitled to study leave as an intern, unfortunately, but from the following year, you'll be entitled to it, and you can be granted study leave for up to 7 days. Long service leave is not likely to be relevant to you guys for a number of years, but it is something that's available to you. And, certainly we can also help you out with that when the time comes. There's also special leave, which can be used for a number of categories depending on the circumstances, but an example of special leave is to be a blood donor or attend jury duty. And of course, there are also options for leave without pay if you meet certain criteria. So another resource that the Workplace Relations team have put together for interns in 2021 is our internship guide. Again, I'd encourage you to take a look at it. It's on our website. There are a number of really useful articles in there. If we were meeting face to face, we'd have some printed ones to give you, but unfortunately that's the environment that we're in. So head to our website and have a look at the guide. There are some really useful articles on understanding your pay and medical records, and summaries of some of your key entitlements as well. So head there and take a look. As I mentioned before, we have our Doctors in Training Committee where you can get involved in advocacy if that's something that you're interested in getting involved in. They meet once a month, and any doctor in training can join. We're actually meeting tomorrow evening. You can get involved by either just attending the committee meetings, or there are often working groups that sort of break away from the Doctors in Training Committee, and they report back on particular areas of interest. You're also welcome to come and have a chat about some of the issues that are going on at your hospital. So we encourage engagement in that committee in any way that you'd like to be involved. So it's something I'd really encourage you to do if that's something that you're interested in. We also have a wonderful careers service with Jessica Rankin, who's been providing some fantastic advice to our doctors in training. So you can get access to advice on career planning. You know, Jess can review your CV. We can also provide you with advice on interview preparation. She's been doing a lot of mock interviews lately. Or you can just, give her a call to have a look over your CV and get some tips on formatting or anything like that that's related to your career. So as I said, I'd really encourage you all to join today, and you can do that by looking at our website, and you can also Google AMA New South Wales 2021 interns to take a look at the offer we have for the Littmann 3 stethoscope. I appreciate tonight has run a bit over, so I don't want to keep you any longer than you need to. I'm sure you've got things to go to, but if you have any questions, you can always call us or you can email workplace@amanewsouthwales.com.au, and we can either arrange a time to have a chat or we can answer your questions by email. So thanks so much.
Thanks so much, Annabelle and Shirley as well. So that completes all of the speakers that we have for you tonight. There's just a few more things that I'm going to very quickly in 2 minutes run through. I promise I won't take very long. Oops. Okay, hopefully everyone can see my screen. It's just loading. Yep, so in terms of the prizes, make sure you fill in your survey. It's very, very quick. It should take you like less than 10, not even 10 minutes, like 2 minutes. And you're going to get a $20 Visa gift card. That's on WSMS. If you're in 5th year, for BOQ has happily donated a $100 Visa gift card. Grimsey has donated a professional package to a lucky student, and GP Synergy has also donated Velch Allen otoscope. So thank you to all of the sponsors for doing that. And finally, just some concluding remarks, and I'll make them very, very quick. Sorry for running a little over time. Thank you to all of our alumni speakers. I've definitely learned a lot of things, and I'm sure everyone has as well. So thank you to them. Thank you to all of our sponsors, and of course, all the students that turned up tonight. So best of luck with internship, and obviously congratulations on finishing. And you guys are going to be great interns. If you have any questions at all, feel free to ask, to message me, as well as message any of the speakers that have spoken tonight. And if you message me, I'm sure I can get you through to them. So thanks so much, everyone, and have a good night.